Good afternoon, and welcome to the Mental Health and Effects Community Engagement Session. I'm Jim Berger. I serve as a Senior Advisor for Blood and Tissue Safety and Availability for the Office of Infectious Disease and HIV Policy, which is part of the Office of the Assistant Secretary for Health. I have the honor of opening the meeting and providing you with the 5 meeting objectives. The first is to validate both the patient and the caregiver experience. The next is to provide education to the audience about the subtle and significant mental health challenges of tick-borne diseases and associated illnesses and conditions. The third is describe potential neurological effects of certain tick-borne diseases and associated illnesses and conditions. The fourth is to provide resources for patients and caregivers seeking help with the mental health effects of tick-borne diseases and associated illnesses and conditions. And the last is provide and furnish information to help healthcare providers recognize, treat, and proactively address the mental health effects of tick-borne disease and associated illnesses and conditions. With that, I'm honored to introduce my boss, Kay Hayes, who serves as the Deputy Assistant Secretary for Infectious Disease and the Director of the Office of Infectious Disease and HIV/AIDS Policy. I had the distinct honor for the last 6 years of serving with Kay as the co-designated federal officer for the Tick-Borne Disease Working Group. With that, Kay, I'm turning it over to you.
Great. Thank you so much, Jim. And it is my honor. Jim is our senior lead in this space and is just an incredible leader. So I am humbled and honored to be serving in this capacity. Just good afternoon to everyone, and we want to say a heartfelt thank you for joining us in this critical, important topic. Admiral Levine sends her remarks and her commitment to move forward in the work that we do. So as we start off this meeting, we'd like to hear some remarks from Admiral Levine. As we talk about Admiral Levine, she serves as the 17th Assistant Secretary for Health for the U.S. Department of Health and Human Services after being nominated by President Biden and confirmed by the Senate in 2021. As Assistant Secretary for Health, Admiral Levine fights every day to improve the health and well-being of all Americans. She's working hard every day to build a stronger foundation for a healthier future. Admiral Levine is also the head of our U.S. Public Health Service Commission Corps, one of the 8 uniformed services. After graduating from Harvard College and Tulane University Medical School, Admiral Levine completed her training in pediatrics and adolescent medicine at the Mount Sinai Medical Center in New York City. As a physician, she focused on the intersection between mental health and physical health, treating children, adolescents, and young adults. Admiral Levine was a professor of pediatrics and psychiatry at the Penn State College of Medicine. In her previous post included Vice Chair for Clinical Affairs for the Department of Pediatrics and Chief of the Division of Adolescent Medicine and Eating Disorders at the Penn State Hershey Medical Center. In 2015, Pennsylvania Governor Tom Wolf nominated Admiral Levine to be Pennsylvania's Physician General, and she was subsequently unanimously confirmed by the Pennsylvania State Senate. In March of 2018, Admiral Levine was named Pennsylvania's Secretary of Health. During her time in the state government, Admiral Levine worked tirelessly, addressing Pennsylvania's opioid crisis and focused attention on maternal health and improving immunization rates among children. Admiral Levine is a member of the National Academy of Medicine and a fellow of the American Academy of Pediatrics, the Society for Adolescent Health and Medicine, and the Academy for Eating Disorders. She was also the president of the Association of State and Territorial Health Officials. In addition, in her recent post in Medicine and Government, Admiral Levine is an accomplished speaker and author on numerous publications on the opioid crisis, adolescent medicine, eating disorders, and LGBTQI medicine. Admiral Levine is our fearless leader. She keeps us to task every day, and this work is critically important to her. So without further ado, Admiral Levine.
Good afternoon, and welcome to the Tick-Borne Diseases and Associated Illnesses Virtual Community Engagement Session. I want to first thank you all for joining us today to discuss a very important and complex topic related to tick-borne diseases and associated illnesses. Ticks are a serious and growing public health concern that affect individuals, families, and communities across the nation. As temperatures rise and environmental changes occur, tick-borne diseases and related conditions continue to increase as well. Earlier this year, we held our first community engagement session in San Francisco, where we asked for your input to help guide our work regarding these virtual meetings. I sincerely appreciate you providing your thoughts, as HHS truly benefits from your feedback. At the San Francisco meeting, this community identified mental health and neurological effects of tick-borne diseases and associated illnesses as a topic of importance. Tick-borne diseases like Lyme disease and conditions like alpha-gal syndrome are multifaceted and have profound effects on individuals that extend beyond just physical health. Living with a chronic illness can take a serious toll on one's mental health, but a tick-borne disease or associated condition itself can also cause neurological or psychiatric symptoms. For example, Lyme disease can target the nervous system, cause meningitis, and Powassan virus can also cause encephalitis or inflammation of the brain. These are just a few conditions that show the complexities of tick-borne diseases. As we move through this session today, we will hear from experts to learn more about these complications and others that occur as a result of tick-borne diseases. The mental health and neurological effects that arise from these already devastating diseases make patient care, diagnosis, and treatment even more difficult, and often negatively impact the quality of life for those affected. The interaction between tick-borne diseases and mental health and neurological health is complex and requires a holistic approach to fully understand and address. Our goal for this session is to raise awareness of how tick-borne diseases and associated illnesses can cause mental health and neurological effects, and to also validate the experiences that so many patients and caregivers endure while fighting with these diseases and conditions. During this meeting, you will hear from esteemed clinicians and researchers who will share their insights and expertise about the connections and complexities between tick-borne diseases and mental and neurological health. When the Tick-Borne Disease Working Group sunset in 2022, I assured this community that HHS's public engagement on tick-borne diseases would continue. That is what we aim to do with these engagement sessions, and my hope is that you will find today's session informative and educational. I want to thank you for being part of the next generation of solutions for tick-borne diseases and associated illnesses. We look forward to welcoming you to our community engagement sessions in the future, both virtually and in person in Portland, Maine in June 2025. Once again, thank you for taking the time to engage with us as we work to create a safer and healthier nation for all.
Thank you, Admiral Levine, for those wonderful remarks. As she mentioned today, this session is an important part of the step in our process for us here at HHS, because we stand committed. Mental health and neurological effects of tick-borne diseases was the topic that you all identified. You identified and we heard you. We would like to hear more about that and talk about the wonderful meeting that we had in San Francisco in June of this year. Today, we are pleased to bring together clinicians and researchers who specialize in this field to share their expertise and to educate us about the mental health and neurological surrounding tick-borne diseases and associated conditions. The purpose of today's meeting is to engage this community and the public in an informative manner to bring awareness to the mental health and neurological effects of tick-borne diseases and associated illnesses and conditions. With this session, we aim not only to provide an educational opportunity to learn, but to also talk about the challenges of tick-borne diseases. And we hope to validate your concerns and your experiences as patients and caregivers. As we mentioned earlier, this topic was identified in the public meeting in San Francisco to be the focus of one of the virtual community engagement sessions. So again, you said it, we heard you, and we are following through with our commitment. The other two topics selected with overwhelming interest at that meeting for our upcoming virtual sessions were diagnosis and diagnostics and treatment of tick-borne diseases. Throughout the duration of the Tick-Borne Disease Working Group, which Admiral Levine did say sunset in December 2022, we heard your concerns about delayed and missed diagnoses, prolonged treatment, and to manage these debilitating conditions, and how these diseases and illnesses cause reoccurring and long-lasting symptoms. We continue to hear you, and we continue to do the work that we need to do. We will hear more important information about these future virtual sessions later today, and then we will have an in-person engagement in Portland, Maine. Again, thank you, patients, family members, advocates, scientists, researchers, clinicians, and I hope I have not forgotten anyone, everyone, for attending this session today to learn more about mental health and neurology surrounding tick-borne diseases. So without further ado, let me introduce to you our first presenter. With that, I would like to introduce our first speaker, Dr. Brian Fallon, to discuss the neurologic aspects of tick-borne diseases. Dr. Fallon is the director of the Center for Neuroinflammatory Disorders and Biobehavioral Medicine and the director of the Lyme and Tick-Borne Diseases Research Center at Columbia University. So with that, Dr. Fallon, the floor is yours.
Thank you. Thank you very much. I also want to say how grateful I am to HHS for organizing this presentation series. I mean, it's extraordinary to think that there is going to be this series on mental health and neurological effects. So I'm very happy about this. Okay, I have no financial disclosures, and I will be discussing off-label use of medications. Briefly, I'll address diagnosis and present a few clinical cases. My focus will be on Lyme disease because there's the most evidence on Lyme disease. I'll talk about mechanisms of disease. I'll talk about a nationwide study that we conducted in Denmark looking at mental disorders. And briefly at the end, I'll cover the treatment of long hauler syndromes. Now, if a patient is not known to have had acquired infection with Borrelia burgdorferi, 10 to 15% of those patients who are untreated go on to develop neurological signs. Early on, it may be meningitis, cranial neuritis, radiculoneuritis. Later on, it could be a chronic polyneuropathy or an encephalopathy, which is the cognitive problems. And these can arise much later. So it could arise months after the initial infection or even years after the initial infection. Much less common would be cerebellar ataxia, myelitis, encephalomyelitis that might look like MS, pseudotumor cerebri-like syndrome in children, or vasculitis may occur in the brain, leading to seizures or stroke. Spirochetes like Borrelia reach the central nervous system quickly, within 2 weeks after the initial tick bite, and 50% may not show CNS symptoms. The central nervous system infection itself, as a relatively sequestered bodily organ, the brain, has treatment implications. So doxycycline, for example, does cross the blood-brain barrier, but not as well as ceftriaxone. So if you have neurologic Lyme disease, most people think ceftriaxone is the safest choice. Culture and PCR studies are not particularly sensitive in the spinal fluid. Those really, even if it's negative, it doesn't mean a whole lot. So here's a person who came to one of our research clinics to participate in a study, a 35-year-old physician and gardener. Obviously, this is not her real picture, but she initially was suffering with fatigue, irritability, muscle pains, cognitive problems, all occurring after a tick bite. She didn't have a rash, but she knew about Lyme disease, so she went to her physician, and even though she didn't meet CDC clinical criteria for Lyme disease because she didn't have the rash, the physician did subsequently test her after a few weeks. She tested positive, and treated her with doxy. Now, she should have been treated right away, I think, but anyway, he waited just to make sure, and then she did test positive, so he treated her with doxy, and she got 90% better. So that was very encouraging. But then 3 months later, she relapsed, and she developed some new symptoms: joint pains, stabbing pains, light and sound sensitivity, depression. She felt miserable. So she went back to her primary care doctor, who denied further treatment because he said she had gotten a curative course of treatment. So she couldn't believe it because she was perfectly well until she had that tick bite. So she went back to other colleagues and said, would you be willing to treat me? And she found one that would, and she got treated, got better. She relapsed again 3 months after that. She got treated again, and that time she stayed well. So she asked herself, what is going on? Are the patients right that in fact some patients may need repeated courses of therapy? So 20% of patients with Lyme disease do not see a rash. They just don't see it. Cognitive problems occur. They're often referred to as brain fog, similar to what you see with long COVID. Other symptoms are quite common, such as light sensitivity, sound sensitivity, paresthesias, numbness or tingling or burning sensations, neuropathic pain, irritability, and depression. What would have happened if this physician hadn't had the connections to be retreated? Is there any evidence of a benefit of antibiotic retreatment? The Lyme disease treatment guidelines do not recommend more than one course of treatment, except for arthritis. However, 40% of clinicians in the US do give additional courses of antibiotics. So it does raise the question of whether infection can persist after antibiotic therapy. That's widely been discounted by the academic community until animal studies proved otherwise. Now, there's been human studies of people with persistent symptoms to see if a repeated course of antibiotics might help. These were small studies. The first one was done by Dr. Krupp at Stony Brook. She gave 1 month of intravenous ceftriaxone and compared it to placebo and found that after 6 months, 64% of those who had given the active drug, in fact, were clinically better with fatigue, which was her primary outcome. We conducted a study looking at cognition to see if 10 weeks of IV ceftriaxone would be helpful. These people had all had robust prior treatments, including IV ceftriaxone, so we wanted a longer course than they had initially had. And we found the same results in terms of fatigue, not in terms of cognition. So we found that about 2/3 were better with ceftriaxone and only 25% on placebo. And the effect size was moderate to large. So when you have two studies that find similar results, that gives significant strength to believing in the results from the original study, because this was a secondary analysis, but this was the primary analysis at Stony Brook. Both studies, however, had safety concerns related to the PICC line and IV administration, leading to not recommending the treatment given the risk-benefit issues. So it's not like the treatment didn't work, it's just that the risks are considerable with the intravenous antibiotics. Now, here's a really interesting case that really struck me and led me into this field, which was in 1988, a paper was published called The Bicycle Boy. This boy was bicycling compulsively. He wouldn't stop, and he lost a tremendous amount of weight. So he was admitted to a psychiatric hospital. Interestingly, in his history, prior to getting withdrawn and depressed and not being able to communicate and function, he had Lyme arthritis. And he got 1 course of 30 days of doxycycline. His arthritis went away, but then all of these psychiatric symptoms emerged. And so he was admitted to a psychiatric research facility or clinical facility at Yale. And they recognized the Lyme arthritis history, and they thought, well, maybe we should have a neurologist evaluate him. So they did. And the spinal tap revealed elevated antibodies against Borrelia burgdorferi in the spinal fluid, which led the neurologist to treat with intravenous penicillin, which is what they gave at that time. And he got dramatically better, dramatically better. So during the following several months, his behavior returned to normal, and he remained well for the next 2 years, which was a follow-up period. So that's quite stunning, that severe obsessive compulsive behaviors could be improved with antibiotics. Okay, so was this a case of PANDAS? PANDAS refers to pediatric autoimmune disorders associated with strep. Well, obviously he didn't have strep, but he did have Lyme. So maybe this was pediatric autoimmune disorder associated with Lyme. However, was it an autoimmune disorder? Perhaps, but clearly the active infection was the leading stimulus, because when he got treated with antibiotics, the problem went away. So what's the normal diagnostic test that you do with these patients? Blood tests, of course. If you're interested in doing a thorough neurologic assessment, you might do a spinal tap, looking at the cerebral spinal fluid. If there's neuropathy, especially large fiber neuropathy, you may look for EMG or nerve conduction studies. You might do a skin biopsy to assess small nerve fibers. If you're interested in finding see if the brain is involved, you might do an MRI to look for hyperintensities, or SPECT or PET imaging to look for changes in metabolism or blood flow. And that can be helpful if you have, let's say, nobody's believing the 18-year-old boy who is stuck in a wheelchair and can't go to school and has headphones on his ears and has to wear dark sunglasses because he looks so weird. Nobody believes him. They think he's making it up. But he's been in this situation for 6 months to a year. So then you do let's say a PET scan or a SPECT scan, you see markedly decreased blood flow or metabolism. Well, that tells you that there's something real going on. It's not a psychosomatic disorder. There are other tick-borne pathogens and associated pathogens that we often look at. So Borrelia miyamotoi, that's an emerging pathogen first described in the United States in 2013. In our second opinion clinic, where people come to us because of their interest in the possibility of Lyme disease as to whether that might be causing their symptoms. They have Lyme-like symptoms, but they've never been diagnosed with this because they test negative. But when we tested them for Borrelia miyamotoi, which is also carried by the same tick that carries the Borrelia burgdorferi, nearly 98% of those patients had never been tested for it, and 25% of those patients were seropositive for Borrelia miyamotoi. So that was very comforting to the patients to know actually what was causing their chronic symptoms. And it's treatable with antibiotics. Bartonella species, not mainly tick-borne, but flea-borne, and it's associated with neuropsychiatric disorders. Powassan virus is rare, but can be deadly. You'll hear more about that later. The Bartonella is really interesting to me. It's extremely ubiquitous, meaning that it's all over the place. Many humans are carrying it. So many humans, including healthy people, will test positive on the antibody tests for Bartonella. It doesn't mean you have active Bartonella in your system. It just means that at one point you were exposed. But there was a study done by Ed Brightsworth at North Carolina State University where he looked at Bartonella in individuals with psychosis versus healthy controls, and he found a higher rate. And that stunned me when I saw that, because that was a controlled study, and it was a small study, however. So I thought, well, let's repeat the study, and let's make it more credible by, it's not that I disbelieve Dr. Brightsworth, but I think it's better if you have an external person conducting it. So we had collected samples. Dr. Delaney in my group had collected samples from patients with psychosis and family members without psychosis and healthy controls without psychosis and children. So she sent to Dr. Brightsworth's lab in a blinded fashion all of these samples. And what they reported was a threefold higher rate of Bartonella DNA in the adults with psychosis compared to the controls without psychosis. So it was 43% versus 14%. That was striking. Now, it doesn't mean that Bartonella is causing the psychosis, but it certainly does raise the question to why is Bartonella associated more strongly in these individuals with schizophrenia than those without? And there have been case reports of people with Bartonella infection who are psychotic getting better with antibiotic treatment. But just like other studies, no difference was found in Bartonella seroreactivity between the patients and the controls. So we know that ticks can carry more than Borrelia burgdorferi. They can carry a whole range of other microbes, including Anaplasma and Babesia. And sometimes you can get a dual infection, maybe 1% of the time with Anaplasma and Babesia, Anaplasma and Borrelia, or Babesia and Borrelia. Or you could have triple infection. That's rare. In one study, it was 0.1%, but that can occur as well. So what does it mean to the person from a clinical experience level when they get more than one infection? We know that brain metabolism and blood flow are decreased in the brains of patients who have post-treatment Lyme symptoms. We know that there's evidence of microglial activation, which is a marker of inflammation in the brain of these patients. We know that spirochetes can persist despite antibiotic treatment, and that's because of the studies that have been done in animals primarily, but there have been some studies in humans as well. And these are all the different animals that are hosts to Borrelia. And rarely, Borrelia may persist in the central nervous system despite treatment. We don't know whether it's doing nothing, either it's quiescent or whether it's actually inducing disease. This was a spirochete found in the brain of one of my patients after she died with Lewy body dementia 15 years after contracting Lyme disease. We don't know if Lyme disease had anything to do with the later dementia, but it is striking that the spirochete was found in her brain. Now, there was no inflammation in that area, which suggests that maybe it wasn't causing any disease, but it does raise further questions. A key message I want to convey to everybody is that most mental disorders have nothing to do with Lyme disease. Just remember that, because if you're focused on Lyme like I am, you might think that you might overdiagnose it. We know from studies of Lyme disease that people can develop OCD, panic attacks, mood disorders, suicidality, light and sound sensitivity, cognitive problems, and rarely they might have a new onset manic episode or a psychotic episode or a tic disorder. Why? Why would these things occur? Could occur because Borrelia induces inflammation. It could be because there's an autoimmune reaction where antibodies cross-react with the Borrelia and then cross-react with the human tissue. It's called molecular mimicry. Or it could be that the brain has been altered in some ways, altered neural circuitry. There's other mechanisms as well. Those are the main ones. If you do a study of people with post-treatment Lyme disease, up to 90% will report having cognitive problems. And if you do objective extensive neuropsychological testing, about 10 to 30% will have objective problems. Now, here's two really interesting cases. One of a 55-year-old woman who presented with new onset manic psychosis. She had been camping with her family, suddenly developed 55-year-old. You shouldn't be developing new onset mania at that point, but she suddenly did. So she was brought to the emergency room and she was admitted to the psychiatric inpatient facility. And after 2 or 3 days, she started to develop radicular pain down her leg and weakness in her leg. So they called in neurology. Neurologists thought immediately of Lyme disease because Lyme disease in Europe is well known as causing radicular pain and weakness, as well as encephalitis and meningitis. And so they thought that she had neuroborreliosis because of the encephalitis and radiculitis. They did a spinal tap. Her antibody index against Borrelia was negative. So they could have concluded that, oh, you don't have Lyme disease, but they correctly said, we believe strongly that she does have Lyme disease and she won't test positive on the antibody test because it's too early. So, so they treated her. She got dramatically better, both with her neurologic and her psychiatric symptoms. They went away. 8 weeks later they repeated the tap, and it was positive, confirming the original diagnosis. So then there was another really interesting case of a 42-year-old woman who presented with cognitive problems, irritability, and then she developed paranoia. And then she developed hallucinations, and she was hospitalized for 8 months. And a variety of psychiatric meds were ineffective. She finally got a lumbar puncture, and the neuroborreliosis was diagnosed. That's neurologic Lyme disease. And she got treated and got dramatically better, full recovery. So these are striking cases, rare cases, but you don't want to miss them. So the key message, both underdiagnosis and overdiagnosis can be problematic. Underdiagnosis, if a psychiatric disorder is present but a Lyme infection is not treated, then the mental health interventions will be less effective or ineffective. However, if tick-borne diagnosis is incorrectly applied as the primary cause of a psychiatric disorder, then the patient's psychiatric disorder may be overlooked. The patient may not want to go see a mental health provider, and that may lead to severe adverse consequences, including death. So be careful of both underdiagnosis and overdiagnosis. We know from studies in rheumatology clinics, here is one, where depression was found 4 times more common than in the other comparison groups. So there's something about mood and in these patients with chronic Lyme symptoms. We looked at suicidal ideation and found that 20% of our patients had suicidal ideation. And if you focused only on those who also had depression, 2/3 had suicidal ideation. So this is really disturbing because it makes me think that we're not asking the question enough of our patients. What's your mood like? And do you have suicidal thoughts? So a few years ago, I was thinking, why is it that the world really still doesn't acknowledge that there are psychiatric problems associated with Lyme disease? And I thought, well, our studies really have been problematic. Small sample size, unclear diagnostic criteria in some studies, ascertainment bias. They come to a psychiatric clinic for the study. Of course, they're going to have a higher rate of psychiatric disorders, lack of an appropriate control group. So I thought, well, what can I do? What will convince the world? And I thought the only way the world will be convinced is if there's an epidemiologic study that's completely unbiased, done by someone else, not by me. So I contacted Michael Benrose in Denmark, who's one of the world's best mental health epidemiologists. He agreed to conduct the study. And so this was a study of 7 million people, all the people in Denmark over the course of 22 years. And there were 12,616 people who had new onset Lyme disease during that 22-year period. And he asked, is the frequency of mental disorders or suicide higher in the group with Lyme disease than the comparison group? What he found was that it was increased. Any mental disorder in the Lyme group, 30% increase. Depressive disorder, 40% increase. Suicide attempts were increased twofold. And there was a 75% increase in suicide in the group with Lyme disease compared to those who had never had it. And then if you look, there was also a temporal and a dose relationship, meaning that if you're closer in time to when the Lyme disease diagnosis occurred, your rate is increased. If you've had more than one episode of Lyme disease, your suicide and any mental disorder risk is increased. So are these results surprising? The answer is no. Serious infections are associated with increased rates of mental disorders. One study found that 7 or more hospital-based infections was associated with a 3-fold increased risk of suicide. And many infections have been associated with neuropsychiatric disorder. This we know, certainly most emphasized during COVID pandemic. So what are my clinical recommendations? Monitor your patients for mental health sequelae from Lyme disease, especially during the first year after diagnosis, and among those with chronic symptoms. Consider incorporating the PHQ-9 for depression or the Columbia Suicide Severity Rating Scale into your practice. And refer to mental health clinicians. Give your patients the Suicide Prevention Lifeline phone number 988. It's manned and womaned by people who know a ton about suicide, and they really want to help. So what is the Columbia Suicide Severity Rating Scale? It's so simple, just 6 questions. And this has been used around the world. And I have an app on my phone called the Lighthouse app that actually gives you these questions in case you're talking to someone who's got suicidal thoughts. You can ask these questions in a systematic way. So have you wished you were dead? Have you had thoughts of killing yourself? Have you been thinking about how you might do it? Have you had intention to act? Have you started to work out the details? Have you started to act on your plan? So any of these things in red here should indicate to the clinician, I need to send this patient to the ER, or I need to have a mental health provider immediately evaluate this patient, because this is a very high risk. These are more moderate risk responses if they acknowledge having thoughts, but not planning to do anything. So you're a clinician. When should you suspect that neuropsychiatric symptoms may be Lyme related? Certainly if multi-system symptoms emerge after a viral-like illness and exposure to a Lyme endemic area. Certainly if there's other evidence such as seroconversion or increased titers or abnormal spinal fluid. And certainly if it occurs in someone who is previously psychiatrically completely healthy, or if it's manifesting at an odd age. Now, what are some of the things I do in my practice as a psychiatrist, when I'm practicing as a psychiatrist? I use the standard things that a psychiatrist would use, and oftentimes they can be very helpful. So bupropion or modafinil can help with fatigue. Central pain, which is a brain intensifying problem that accentuates pain, and neuropathies. So tricyclics, low-dose tricyclics like amitriptyline can be enormously helpful. SNRIs like venlafaxine or duloxetine can be very helpful. Pregabalin or gabapentin, low-dose naltrexone, cannabinoids. And a recent open-label study at Hopkins suggests that psilocybin can be helpful as well in reducing pain and fatigue. For light and sound sensitivity, this is really problematic. Gabapentin, carbamazepine, and clonazepam can reduce the sensitivity, but it doesn't take it away completely, and it can be this needs a lot more work. Mood dysregulation, depression, and attention can be helped to some extent with the standard treatments. We did a study of Kundalini yoga group therapy, and the patients who participated loved it. They were really happy with, I think, the group context of talking about other people who had similar symptoms, but they also reported greater improvements than those who were on the wait list in symptom severity and in cognitive complaints. Now, what do we know about long hauler syndromes and what might help them or what's being looked at? Well, they have the same symptom profile: fatigue, trouble concentrating, muscle pain, memory problems, sleep problems, irritability. What you see in post-treatment Lyme is also there in COVID, except for the anosmia and the dyspnea, which is more common in COVID. So potential therapies that help COVID will help Lyme, and similar back and forth. So if you have to think mechanistically, what are you targeting? Are you targeting persistent infection, in which case you might want to give antibiotics or antivirals? If you're targeting immune activation, you might want to give IVIG, such as they do in autoimmune neuropathies, or biologics that target specific inflammatory pathways. Are you targeting the autonomic dysautonomia that occurs or altered neural transmitter systems? Then you want to use treatments that are appropriate to those. Are you targeting an altered microbiome? There's some emerging evidence that some experimental treatments may be helpful. Neuromodulation or brain stimulation may be very helpful. Stress reduction and psychotherapy has to be helpful, and rehab can be very helpful. So here's a book. Take a look at it. Peter Rowe wrote this wonderful book on orthostatic intolerance, filled with tools on how to help, tips on all the different treatments for orthostatic intolerance. It just came out. I get no rewards for telling you about his book, except for enjoying the fact that you might actually learn a lot from it. Orthostatic intolerance can cause brain fog, fatigue, and lightheadedness, which so many of our patients suffer with. So take a look at this book. And there's so many different treatments that can be considered. So what are we doing at Columbia? Well, we started a clinical trials network coordinating center with the generous gift from the Stephen and Alexandra Cohen Foundation. We now have 8 different principal investigators around the country, on the West Coast and the East Coast, at many of the major medical centers. And the exciting news about this is that people are actually starting to study the chronic symptoms associated with Lyme disease in a systematic way to see all these different treatment approaches that might be helpful. So for persistent infection, they're looking at tetracycline or pulse IV ceftriaxone. For dysautonomia, they're looking at vagus nerve stimulation. For central nervous system dysfunction, they're looking at transcranial direct current brain stimulation, which is this here. These are all at-home therapies, these brain stimulation treatments. Scott Cummins, you'll hear, perhaps he'll talk about immune dysregulation related to post-tick bite illness and with a mast cell modulation study. Microclots and platelet hyperactivation are being studied at Mount Sinai using a proteolytic enzyme. And there's a prenatal Borrelia infection study to look at neurodevelopmental outcomes being conducted by Dr. Mulkey at Children's National Hospital. So if you ever encounter a pregnant woman who recently had Lyme or currently has or was diagnosed during pregnancy, please have them call Dr. Mulkey. So summary: symptoms of neuropsychiatric Lyme: mood, cognitive problems, suicidal thoughts, sensory arousal, common. Screen for depression and suicidal thoughts. Easy to do. Please do it. People also have concurrent neuropathic and arthritic symptoms often. Course of neuropsychiatric Lyme symptoms, it can occur early or it can occur late in infection. Many improve over time, but it may take years. Some have residual significant cognitive neuropsychiatric problems. What we don't know are the long-term effects of non-Lyme tick-borne illnesses and associated infections and conditions. That's never been systematically carefully studied. We don't know the long-term effects of having more than one tick-borne or associated infection. So this all needs to be investigated. And in terms of treatment, number one, I assess for the adequacy of prior antimicrobial treatment. If I don't think it was adequate, I recommend an additional course. Focus on the most burdensome symptoms. Validate, and acknowledge the limits of our knowledge. And I tell patients, do not avoid standard mental health treatment because these can enhance recovery and improve the quality of your life to a great extent. And be hopeful because new treatment approaches are in development and being tested. Thank you for your attention.
Great. Thank you so much, Dr. Fallon. And I just think your summary was so comprehensive. And when I looked at your treatment as part of your summary, for me, leaving with that message of hope was spot on. Just really, when I looked at some of your data that you shared, and you talked about up to 90% of people who meet the criteria for post-treatment Lyme disease syndrome complain of cognitive difficulties. However, only about 7 to 30% of those people have measurable symptoms. Want to ask you, what can frontline clinicians do to help ensure that individuals are diagnosed in a timely manner?
That's a great question and super important, obviously. Cognitive problems don't usually occur in young people or middle-aged people. They do occur in older people already. So if you have verbal fluency or word-finding problems, that is not that uncommon. But when it occurs in younger people or middle-aged people, then you have to start thinking that something else is going on. Or people who have depressive symptoms or new onset irritability that are also accompanied by joint or muscle pain or numbness, tingling, burning pains, or light and sound sensitivity. All that suggests that a workup for Lyme disease or another tick-borne illness could be very valuable. Another point is that if someone develops new onset viral illness during the summer season, you definitely have to think about that this might be Lyme disease or another tick-borne infection. And if it's accompanied by high fevers, hopefully that person will go right to the emergency room and get evaluated for the possibility of anaplasma or ehrlichia, because those can be life-threatening infections unless they're rapidly treated with doxycycline. You're on mute.
Thank you. Also, just wanted to ask another question. How might your average patient go from presenting with symptoms to their primary care provider and really getting the expansive testing that is needed?
That's a really good question because a lot of physicians aren't aware of the variety of tests that are needed. So um, certainly, there are a lot of Lyme disease organizations around the country that provide a lot of helpful information to patients. The CDC has an excellent website with a lot of information as well. So I think it's really finding a physician who has experience working in this area. And there's academic experts at the many of the academic centers who are participating in our CTN. And I encourage patients who are listening to join our Lyme registry. Just sign up for it. Go to lymectn.org. And there's a registry there, and that way you'll learn about all the new studies that we're doing.
Great. Thank you so much. I probably have like 10 or 15 more questions. But for now, we will move on to our next presenter. And I just want to end with, if you wanted to leave one takeaway message for our listeners, our family that's listening into this, what would you say to them?
I would say that even if you're feeling severely ill, even if you've been ill a year or 2 years or even 3 years, don't despair because it's obviously a life-changing illness. But over time, I did a 10-year follow-up study. And in that 10-year follow-up study, I was extremely encouraged to see that a third of those patients were well, and another third were substantially better than the first time I saw them. And these are people who were severely, severely ill, who had been ill many years and had tons of prior antibiotics. So the fact that they were doing so much better 10 years later is hopeful.
Great. All right. Thank you so very much.
Okay.
All right. As we move on to our next presenter, I'm happy to say that we have Dr. Liz Nekrovich, Division of Emergency Medicine at Boston Children's Hospital and a professor of pediatrics at Harvard Medical School. So welcome.
Thank you. Thank you, Kays, and the whole group for inviting me to present today. Thumbs up if you can hear me just before I go too far. Excellent. So thank you, and thanks to the audience for devoting what is at least a beautiful afternoon in the Boston area to learning about Lyme disease. And I'm pleased to be here today. Excellent. Okay. So I have no disclosures, but I do want to provide some framing for my next talk. So I'm a pediatrician and an emergency provider. So I work in an emergency room taking care of children with all sorts of medical problems, broken legs, abdominal pain, appendicitis, and sometimes tick-borne illnesses. And for me, as a clinician, an educator, and a researcher, my focus has been making sure that tick-borne illness is considered in the appropriate scenarios and that providers know how to appropriately diagnose and treat children in these conditions. And so my lens is different than some of the other speakers that you'll hear about today, but informs what I will be talking about. Okay, so in our brief time here, what am I going to do? Here's our roadmap for our discussion. So we're going to talk about the clinical manifestations of Lyme disease in children with a focus on the neurologic. And then dive into like how children with or patients with Lyme meningitis should be treated. and somewhat the debate between doxycycline and ceftriaxone, which has informed an ongoing study, which I will focus on, comparing these two antibiotic regimens for the treatment of acute meningitis in children, which is funded by the NIAID, which I will talk about. So here I'm going to start with this age distribution here. Many of you have seen this graph. On the x-axis, we have age of presentation for a reported cases of Lyme disease in 5-year groups. And in the y-axis, we have the percent of cases reported. And so you'll see that there's a bimodal distribution. There's a peak in school-age children, age 5 to 9 and 10 to 14. And then another peak in, I'll say, middle-age adults. And the other thing that you'll note in this graph is that the green line represents males and the red line represents females. And in all ages, Lyme disease is slightly more common, acute Lyme disease in males than females. And this presumably represents exposure. Children have more time to be outside and more likely to get Lyme disease. Again, in older adults, perhaps more time for recreation and outdoor exposure. But I think it highlights how important it is to include children in studies of Lyme disease. And many of the clinical studies don't include children. So as the pediatrician, I always like to remind people that children are very affected by Lyme disease and other tick-borne illnesses. What do we see in the acute setting for Lyme disease? The earliest stages are an EM rash, which can present typically, but often presents atypically. The picture that I've shown here is a fairly typical EM rash, but it's partly obscured by this girl's hair. And so for somebody who didn't take a close look, they might miss the classic bullseye appearance. But we all know that these are often atypical. They can be very challenging to see in a dark-skinned individual. And the classic diagnostic tests perform particularly poorly in the acute setting. Many patients don't have an EM rash. And so there are challenges of relying on this cutaneous manifestation for diagnosis. What about the early disseminated phase? And that is what we'll be focusing on today for neurologic Lyme. It can present as multiple EM lesions, but the neurologic manifestations of the acute disease typically involve a cranial nerve palsy. The 7th nerve palsy, or the facial nerve, is the most commonly involved. And in fact, that's by far and away the most common neurologic manifestation of Lyme disease. And you'll see here in this girl's pictured here, she has a peripheral 7th nerve palsy that is affecting the left side of her face. And so when she smiles or turns up the corner of her eye, the left side musculature is not working the same as the right side. We're going to talk about Lyme meningitis, which is a less common neurologic manifestation of Lyme disease, but a really important one in terms of the long-term consequences and the focus of our treatment study. Carditis is also a manifestation of the early disseminated phase. And last, I'll briefly mention the late acute disease, which is typically arthritis. As shown here, most commonly affects the large joints, and the knee is the most commonly affected. Okay, if you have Lyme meningitis, how should it be treated? And an older guideline published by the IDSA recommends parenteral ceftriaxone as first-line treatment for Lyme meningitis. And this was common clinical practice during the time of my training and initial practice. However, in children, parenteral antibiotics are challenging to deliver. So initially, often they're delivered in a hospital setting, but a 3-week course is challenging, and children want to go home to resume their normal life, especially as they start to feel better. When we followed children that had PICC lines placed in for treatment of Lyme meningitis, many had complications. And in fact, a third had problems with their PICC lines or reactions to the antibiotics, even just with a 3-week course. And so we know this treatment is challenging to administer. And so the question is, are other alternatives equally effective? There's some evidence that doxycycline might be equivalent to ceftriaxone. In fact, there's a number of randomized trials in Europe that took adults with Lyme meningitis and randomized them to doxycycline versus ceftriaxone. And it suggested that the doxycycline was as good as the ceftriaxone. Importantly, the organism, the Borrelia organism in Europe that causes disease is different. It's not the Burgdorferi species that we see most commonly in the US. There's more limited data in children and in the US that of the equivalency of therapy. In fact, there's only one pediatric study, which was observational. That is, practice changed and children received doxycycline for Lyme meningitis. And in this study, they did well. So suggestive, but not confirmatory. Based on this evidence, when the guideline was revised in 2021, and this was a collaboration between several societies, the Clinical Infectious or IDSA, the Neurology Society, and the Arthritis Society, they looked at the treatment for Lyme meningitis. And the guideline is a series of PICOs, or clinical questions with suggested treatments. So the question here, PICO 13, is what are the preferred antibiotic regimens for the treatment of acute neurologic manifestations of Lyme disease without parenchymal involvement of the brain or spinal cord? And so the recommendation, as read here, is that we recommend using intravenous ceftriaxone or cefotaxime and related antibiotic, penicillin G, which is infrequently used, or oral doxycycline. It's a strong recommendation with moderate quality of evidence. So it's basically saying that either antibiotic is an appropriate first-line treatment, which is a change from the prior guideline. And the question is, particularly for children, how good is the quality of evidence? And can we be certain that the treatment is as good for the short and long-term outcomes? So what's unique about children? First of all, there was some concerns about using doxycycline in young children. Tetracycline, which is an older form of doxycycline, is known to cause tooth staining and enamel hypoplasia in children with developing teeth. So pregnant women and young children really shouldn't have tetracyclines. And for a long time, we restricted use of any antibiotic in that class in children less than 8 years of age because they're still forming both their primary and secondary teeth, and we wanted to avoid that complication. However, doxycycline, which is one of the newer tetracycline antibiotics, may not be associated with those complications. And in fact, the American Academy of Pediatrics and other pharmacy societies gathered in 2018 and did a rigorous re-review of the safety data. And their committee recommended, after reviewing this data, that doxycycline is probably safe in short courses in children, even the youngest children. So their final recommendation was that up to 3 weeks of doxycycline would be safe in children of all ages. And that's led to relatively rapid adoption of doxycycline use in pediatrics, including for the youngest children. So here's our work looking at the frequency of doxycycline use for the treatment of patients with Lyme meningitis. So as part of a prospective cohort observational study where we study children with Lyme disease, we look at how they were treated between 2015 and 2023. And so the x-axis shows the year, and the y-axis shows the percent of patients treated with doxycycline. The lighter gray bar is all patients with confirmed Lyme disease, and the darker gray bar is those with confirmed Lyme disease who are less than 8 years of age. So if you look between 2015 and 2023, the use of doxycycline as the primary and initial treatment for Lyme disease has gone up dramatically from 40% to 80%, but the increases in children less than 8 years of age are even more dramatic, where it was very uncommonly used in 2015. But after the re-review of the evidence and the change in the recommendation, the use of doxycycline, even in the youngest children, is fairly similar to all patients with Lyme disease. So our practice is changing quite rapidly. What about Lyme meningitis, and what are the remaining questions for the treatment of Lyme meningitis? I think that the question remains about the optimal antibiotic treatment for children with Lyme meningitis, both looking at the short-term symptom outcomes as well as the long-term outcomes. And then importantly, what are the preferences of patients, caregivers, and providers around those treatment choices, and how can we capture those? So that led to this study, which is funded by the NIAID as referenced here. The aims of the study are listed here. So the aims 1 and 2 are to look at oral doxycycline versus intravenous ceftriaxone for the treatment of children with Lyme meningitis, both on short-term recovery, symptom recovery, and long-term quality of life. Importantly, this is an observational study where we are using complicated, fancy statistical methods to study how this choice of antibiotic affects these outcomes, but we're not randomizing patients. We're letting patients and their providers decide the treatment that they received. And we hypothesize, based on the evidences available to us at this time, that doxycycline is not inferior, it is not worse to ceftriaxone on both the short and the long-term outcomes. But our goal is to study this and make sure that that is in fact the case. Our aim 3 is to examine patient, parent, and clinician preferences to inform these shared decision-making about the Lyme meningitis treatment, because it's important to understand how patients and their providers come at these treatment decisions in informing future guidelines. So we think that most patients and their parents will prefer oral doxycycline based on ease of administration with better side effect profile. But we don't know, and we're asking the families who are affected by this disease how they feel about their treatment choices. So this study is ongoing. We have 21 sites. Lyme meningitis is an infrequent presentation of Lyme disease in children. And so we need to really build a big team, and that's why we needed the support of the NIH to conduct this study. Our 21 sites are located in New England, the Mid-Atlantic region, and Midwest region. I've located the study sites with stars on the CDC surveillance map. And as you know now, the CDC, using laboratory surveillance method, is designating states by their overall incident rates. And those that are shown in the darkest blue colors are high incidence states, which means that at least 10 cases per 100,000 individuals are reported each year. And essentially all the sites are in high or moderately high incidence states. And so we are focused on areas where we're seeing this disease, understanding that it's uncommon. Who are we studying? We're studying children between age 1 and 21 years inclusive who have Lyme meningitis. We define that as a pleocytosis on lumbar puncture if children have that study performed, or patients that have signs and symptoms of meningitis, even if they don't have a lumbar puncture performed. And we consider that a clinical diagnosis of meningitis. And in fact, in our experience, most patients are not getting a lumbar puncture because it's an invasive procedure that many patients and their parents would prefer their child not undergo. They have to have positive 2-tier Lyme disease serology. This is a study of patients with confirmed acute Lyme disease. And so we're requiring the positive test. We're not including patients who are going to be treated with alternate antibiotics, since our primary hypothesis is to compare ceftriaxone to doxycycline. If the treatment team is, because of allergy or other preferences, going to use a different antibiotic, we're not including those patients. We're including patients only within 7 days of starting treatment. And that's because many patients do get better acutely, and our primary outcome is related to the symptom resolution. And so if we included patients who had received too much treatment at the time of enrollment, we might miss the time to resolution of acute symptoms. That is, they may have already have the primary outcome at the time we enroll them. We have developed study instruments in English and Spanish, including informed consents, as well as the tools which are delivered to patients and their families electronically in English and Spanish. However, because the participation requires completion of remote surveys, if they speak another language, we are unable to enroll them at this time. We also did not include patients that have Lyme meningitis and bacterial meningitis at the same time, an unusual clinical scenario. We felt like the treatment of the bacterial meningitis would dictate the antibiotics and the outcome for that child. The study activities are listed here, but when we enroll them, we get a bunch of information about their history, their preferences, understand their baseline quality of life and symptoms. If the children have Lyme meningitis and facial palsy, we capture that using a series of photos so we can look for resolution of the facial palsy. We continue to follow them for symptoms in the first month by an electronic survey that's delivered every day until the patients have had 3 days without any symptoms persisting. But we continue to interview them and get information at 6 weeks up to 6 months, including quality of life and symptom surveys. At 6 weeks, we have a qualitative interviewer who meets with the families and understands their experience with the acute illness treatment. So how are we doing? Our power and sample size says that we need 250 patients to understand whether doxycycline and ceftriaxone, or doxycycline is not inferior to ceftriaxone for our primary outcome measures. We're getting a great reception from patients and parents who are eligible for this study, who are able to approach. So of those that we approach, we're getting 84% to participate, which is great. And to date, we have 149 of our 250 patients enrolled, which is 60% of our sample size, essentially after 2 years of enrollment. How long will it take to finish? We estimate sometime in the peak Lyme season of 2026, we'll get up to our 250 patients, but we're all working very hard and working together to make sure we meet that sample size. What is the timing of enrollment? Lyme meningitis is one of the acute manifestations of Lyme disease. And so we see a lot of seasonality in our eligibility. And so for the patients we've enrolled to date, June, July, August, September are our big enrollment months. And we're still seeing a few. We enrolled one a few days ago. But as the weather gets colder, we see fewer and fewer cases. And then we gear up again for the spring season when we start to see patients in May. So coming to the end of my presentation, I think I want to remind people that neurologic Lyme impacts children. The majority of the acute cases are presenting in the summer. The Lyme meningitis treatment, currently there's limited evidence, especially for children. And so we are embarking on the study that I described. And we hope to answer, is doxycycline inferior to ceftriaxone, or is it not inferior? We're looking both at the short-term outcomes as well as the long-term outcomes, understanding the importance of both in choosing an effective treatment, as well as we're really trying hard to capture the patient, caregiver, and provider preferences as important stakeholders in making these decisions. And we continue to enroll, and we're working really hard to get to our sample size. I want to make a few acknowledgements. Hopefully I have time, but I want to say thank you to the patients and families who agree to participate in the study. I know it is hard to participate even in this observational study at a time when they don't feel well, but it really helps us provide information so we can take the best care of children going forward. PD LymeNet is the network that is conducting this study with 21 sites working hard at this study. There's research staff, there's investigators at each of the institutions that are making this possible, and I want to thank each of them for their hard work. Of course, the funders of this work and the study that I described, which is generously supported by NIAID. So thank you to that. And I also want to acknowledge the Global Lyme Alliance, which provided some infrastructure support to get the network started and funds the observational cohort, which I shared some results from. And lastly, I just want to say thank you to and remember my colleague and friend R.S. Garrow, who was an emergency physician at Rhode Island Hospital, who really helped design the study that I described. He unfortunately passed away from leukemia really the month before we started the study, or right around the time that we received notice of award. And so I do this work in his memory and to thank him for his significant contributions to the work. So that's all I'm going to do. I've shared my email, and I'm happy to hear from anyone about this or take any questions. Thank you.
Great. Thank you so much. Really appreciate your remarks, the incredible work that you're doing, and sharing that with us. And just have a few questions that we'd like to ask you. In your presentation, you talked about, the work that you're doing, but what percentage of children who are diagnosed with Lyme disease develop neurologic Lyme disease?
Sure. So thank you. So the easy answer to that is, especially Lyme meningitis is an uncommon manifestation of Lyme disease. Cranial neuritis is more common. Some of the answers is harder to get at because as a clinician, what you see is sort of depends on where you work. So I work in an emergency department, so I'm more likely to see, the neurologic manifestations of Lyme disease. But I would say of all comers, it's less than 5% have a neurologic presentation of acute Lyme disease. So that's why it's hard. That's why we have to build such big teams to answer these important questions so that we know how best to treat this important group of patients.
Great, thank you for that. Less than 5% is what you said,
Yeah.
at least in the settings that you work
Yeah,
in.
I think certainly for Lyme meningitis is less than 5%. I think facial palsy and other cranial neuritis are a little bit more common, maybe up to 10% of acute Lyme disease, but again, they're not the most common manifestations.
Okay, great, thank you. Is there any information about the likelihood that children with Lyme disease will develop neurologic Lyme disease versus adults?
I think in the acute phase, so first of all, I think children are frequently not studied for all clinical studies. And so it reminds me, your question reminds me of how important it is for research that's looking at children who, are impacted by Lyme disease. They play outside, which is great and important, but they get Lyme disease and we need to study them. So that's a good reminder. I think the evidence that we have right now in terms of the acute manifestations is the prevalence is probably relatively similar in children as in adults. Children have less comorbid conditions. They have less medical history. They have less prior Lyme exposure. And so in some ways their presentations may differ, and the symptoms can be more subtle. So you need a provider who's astutely aware of the potential for Lyme disease and other tick-borne illnesses to think about that, because they're not always as clear about what they're experiencing.
Great, thank you. And that's a reminder when you talk about children, is the diagnosis of neurologic Lyme disease in children relatively straightforward, or are there nuances or other issues that are either over or underdiagnosed?
Sure. So, children with neurologic manifestations, there's a broad differential from other infectious diseases to non-infectious diseases. And so just to start with, when you start with neurologic signs and symptoms, the clinicians have a broad list that they're considering. Specifically around Lyme disease, this audience is well aware of the limitations of acute, diagnostics. Meningitis is a manifestation of early disseminated disease. And so it's relatively early in the course of illness. And so some will not have seroconverted in that the diagnostics rely on the host having responded to the pathogen and developed an immune response. And so if you're early in the course, you may not have that immune response and you could have a falsely negative study. Additionally, if you've had Lyme disease in the past, you can have a false positive, although clinically that's less of a concern, particularly in young children who haven't had as many years of life to have had Lyme disease in the past. But, I think like we talk about, there are limitations to acute diagnostics for sure, and that plagues neurologic manifestations as well.
Great, thank you. And I just have one last question. Like
Yeah.
I said, I probably have 10, but I'll limit myself. I have one last question for you. Can you really talk about the enrollment process of your study? I know you talked about it, but I think that might be of interest to some of our listeners.
Sure. So we are a network of clinicians working in the hospital services, the emergency departments, in infectious disease clinics at these 21 participating centers. And what we do is we work together to identify children with signs and symptoms of meningitis who are being evaluated for Lyme disease. And one of the challenges for this study is that Lyme disease testing takes a couple days to come back. And so the clinical team that's working on this study identifies patients who are potentially eligible, but we aren't able to confirm the eligibility until the results of the test come back. And so at that initial point of contact, we provide families something, an information sheet about the ongoing study with a consent to contact. So we make them aware of the study. We provide them contact information if they have any questions. And we ask them if it's okay to call them in a few days if their tests come back positive. For some of the patients, they're in the hospital, and so they can be contacted directly, but many of the children and their families are at home. And so, of course, if a family's not interested in being contacted about research or this specific research study, then, we wouldn't contact them. But for those families that agree to be contacted, if their tests come back positive, after the clinical team has communicated with the family to convey a treatment plan, we then would reach out and ask them if they're willing to be consented. And our study activities are largely remote, so it doesn't require them to come back to the hospital setting. We try to make it as easy as possible for the families.
Great. Thank you so much. And like I always like to do, is there one takeaway message you'd like to leave with our listeners as we move on to our next presenter?
Sure. So I know we have a mixed audience of patients and clinicians, but I think it's good. Children get Lyme disease. You want to think about it, because I think the more we diagnose Lyme disease and other tick-borne illnesses in the acute phase, the better the children will do. So keep a low index of suspicion when thinking about Lyme disease and evaluating patients with presentations that might be consistent.
Great. Thank you so much. I really appreciate your words and remarks here today. And now we'll move on to our next presenter. So with that, I'm pleased to welcome Dr. Scott Cummins, the medical director at UNC Allergy and Immunology Clinic at Easttown and Associate Professor of Medicine, Division of Rheumatology, Allergy, and Immunology at UNC School of Medicine. So Dr. Cummins, the floor is yours.
Thank you so much, Kay. It's a pleasure to be here, and really want to thank you and Jim for all y'all do. I think there are two other people that I just wanted to mention. As a North Carolinian, certainly the late Kay Hagan really means a lot to us in terms of thinking about the effects of tick-borne illness and her tireless work. But also, I just wanted to mention Pat Smith, because I think she would be really proud of the work that this group is doing and hosting not only these live community events, but a chance to get together virtually. So I want to remember her today as well. So the title of my talk is it's not just the avoidance of red meat, and really trying to give voice to the implications of alpha-gal syndrome. Now, obviously, the first part of this is establishing what is alpha-gal syndrome. So it is an allergy, and I hope to convince you why I believe it's best referred to as a syndrome, but I'll come to that in a minute. Alpha-gal allergy is really an allergic reaction that occurs after someone eats beef, pork, lamb, venison, goat, rabbit, any type of mammalian meat. So for short, we might say it's an allergic reaction after you eat red meat. And as you can appreciate here, the reactions are often delayed. So I'm showing you a series of pictures from one of our participants who we did a food challenge with in the clinic, and showing him at baseline and then at 7.5, and two pictures greater than 8 hours after eating pork sausage. And this is consistent with the type of symptoms that patients may report after they eat red meat when they have the alpha-gal allergy. They'll talk about hives, itching. Frequently, they'll talk about palmar redness and swelling, face, lips, tongue. Then we think about when those progress to a term called anaphylaxis, meaning a severe allergic reaction. So you might have chest tightness. You might have difficulty breathing, low blood pressure, which can give you lightheadedness or dizziness. And what is really remarkable about these symptoms is that they occur delayed. So you eat a hamburger or a hot dog for dinner, and literally nothing will happen for 3 to 4 to 5 to 6 hours later. So as you can imagine, diagnosis is a challenge, but it is diagnosed by a blood test. And fortunately, the blood test is fairly ubiquitous these days and can be ordered by any provider. The symptoms may vary. So I've told you about the most severe symptoms, the anaphylaxis side, but there are patients who get gastrointestinal only symptoms. They will report severe abdominal pain, nausea, vomiting, diarrhea. There are some patients who will say that it feels like they're having an appendicitis or a gallbladder attack. Interestingly, this often happens in the middle of the night. So you don't have to get hives to have alpha-gal allergy. You can have gastrointestinal symptoms. But as I mentioned, I think it really is best considered a syndrome. And why is that? We basically, as a group, sort of renamed it alpha-gal syndrome, or AGS for short. And that is really to reflect that the relevant exposures extend well beyond mammalian meat. So all lower mammals, if you will, non-human mammals have alpha-gal. As humans, we do not have alpha-gal. So you can be allergic not only to the meat from those animals, but the other derived products. So dairy, cow's milk, yogurt, goat's milk, cheese, butter, gelatin, which can appear in medications, in capsules, in vaccines, can be in foods as well. Jello, candy, marshmallows. It can be added to foods for flavor or as a clarifying agent for some wines. And it does not have to be labeled. Also, mammal-based medications. Heparin is the most common. Heparin is derived from pig intestines and cow lungs. And so if you have alpha-gal allergy, you can be allergic to heparin. There are medications that are produced in mammalian cell lines that are really important medicines, can even be some cancer medicines. There are other medications that may contain mammal-derived sources. Carrageenan comes up as well. This is actually a plant. It's a seaweed, but it has alpha-gal. And again, if I put an asterisk here, it indicates that it's an unlabeled allergen exposure. So while you may be able to order chicken instead of steak, it's really difficult to know if the gelatin in your capsule comes from a mammal source or a plant source or a fish source. Moreover, we are really good at utilizing the products from our animals. I'm going to show you the cow derived products here and pigs on the next slide. So I use this slide not to indicate that someone with alpha-gal syndrome cannot play tennis because tennis strings may be derived from the internal organs of cows. That's not my point. My point is that byproducts from these animals find their way into so many different aspects of our lives. And the pig is also not to be underestimated. Again, if you have alpha-gal syndrome, you can still play the drums or play football, but it is to make the point that it goes well beyond just not eating pork. So these mammal-based products find their way into so many different areas of life that I really think it is best considered a syndrome. Now, obviously, we're at a tick-related conference. So how does alpha-gal allergy relate to that? Well, it turns out that tick bites are the reason why patients develop alpha-gal syndrome. And we had long suspected this, but it actually wasn't until very recently, in the past 2 years, that our partnership with the CDC and specifically the rickettsial zoonoses branch, Drs. Kirsch and Salzer, really helped us solidify and establish that, in fact, tick bites are the risk factor for people to develop the specific antibody that is linked to alpha-gal syndrome. If we think about the number of cases and where they are in the US, this is data from the initial study looking at the US distribution of alpha-gal positive blood tests. From 2013 to 2018, you can see not only an increase in the numbers within certain states, but also an increase in the distribution of states who were reporting alpha-gal positive blood tests. This is a global phenomenon, though, as well. So if you have alpha-gal syndrome or know someone who does, they can take to the web and look up ZMAP alpha-gal, and they can drop their own PIN and begin to help us define the places where alpha-gal syndrome exists. So we know it's in the US. We know Australia is a big site for it as well. Includes South Africa and Europe and Scandinavia. It definitely seems to be expanding. When we think and look specifically at the US cases of ZMAP, this also gives us a sense of the distribution. This is certainly not everyone, because these are crowdsourced. So these are people who volunteer to drop their own PIN, but it really gives us a sense of location-wise instead of numbers. Where are we seeing these patients? More recently, in partnership with the CDC and the National Testing Lab, Viracor Eurofins, we were able to define much more specifically, county by county, the number of cases of alpha-gal allergy in the US that have been reported from 2013 now up to 2022. So this includes that prior data that I showed you. And you can again see the reflection in the distribution where it's predominantly a southeastern and east coast phenomenon, but it's now extending into the central US. Suffolk County, New York, on Long Island accounts for 90% of all cases reported in New York and 4% of all the cases overall. But then another very interesting area is looking in the Great Lakes areas where there are cases of alpha-gal syndrome that are seen based on blood work. Interestingly, the tick that is really associated with alpha-gal syndrome in the US, which is the Lone Star tick or Amblyomma americanum, is not thought to exist in some of that Great Lakes area. So it leads us to be concerned and perhaps suspect that there may be other causes, other tick-related causes for alpha-gal syndrome in the US beyond Lone Star ticks. We certainly know from the global map that there are other ticks involved in causing alpha-gal syndrome more internationally, globally, because the Lone Star tick is much more of a US-based population. So we know that alpha-gal syndrome is linked to other ticks throughout the world, but now beginning to have some evidence that perhaps, in fact, it's linked to other tick species within the US itself. So more to come, I think, on that. Now, I really want to make a point, though, today about the mental health burden of living with food allergies, and particularly living with alpha-gal syndrome. We know that food allergies in general impose a large psychosocial burden. There's a mental, emotional, and social aspect to having a food allergy on both patients, but also their caregivers. We know that patients experience heightened emotions around living with food allergies. Food avoidance is difficult, and there's potential for exposure and severe reactions. Each meal, which could be a social time for the rest of us, is a possible reaction for someone with a food allergy. And we know that children with food allergies may face additional challenges, including, unfortunately, bullying and social isolation at school. We know food allergies can affect family life. Many caregivers actually living in fear that their child's life could be threatened by severe allergic reactions. Fortunately, severe and life-threatening and fatal reactions fatal reactions are quite rare. But caregivers can also experience their own feelings of isolation and anxiety which can affect their mental health. And recently, the Food Allergy Research and Education Group called FAIR published a study of their registry of over 1,600 patients and caregivers. And on this slide is data related to a question about emotions. What emotions do you report as a result of eating the food that produced an allergic reaction? And strikingly, anxiety was the first thing that 54% of the respondents said. Panic at 32% was next. You can see the others there as well. But interestingly, they didn't say scared. It was panic and anxiety. They didn't say nervous or uncertain. Panic and anxiety. This comes up again in another question from the same FAIR registry, where they specifically asked about mental health. What types of mental health concerns related to food allergy has the participant experienced? Number 1 and number 2, anxiety about living with food allergies and anxiety after an allergic reaction. I pulled out a specific quote from this publication because I think it relates to alpha-gal syndrome, and you can see it there on the right. Mental health concerns were more prevalent in patients with multiple food allergies compared with a single food allergy. And I would submit that alpha-gal syndrome is a multiple food allergy, not only because of the distribution of alpha-gal in all lower mammals, but also because of the syndrome portion where it extends beyond simply eating or avoiding red meat. In another piece of data from this same study, they looked at the likelihood of mental health concerns in these 1,680 respondents. The odds ratio of 1 is a delineator for increased likelihood of mental health concerns on the right as you go past 1, or fewer concerns on the left as you go less than 1. So for those who reported many or unsure of how many reactions they were having a year, they had a higher likelihood of mental health concerns. Equally, those who experienced 1 to 3 per month, 2 to 3 per year, or around 1 a week also had increased likelihood of mental health concerns. Interestingly, 33% of the respondents indicated that they would like to have been screened for a mental health diagnosis, but less than 10% reported having been screened. And this is important because if you look not at the very bottom, but 1 up, the second from the last, those who actually had a formal mental health diagnosis had less likelihood of having mental health concerns. So we really have a lot to do on the mental health side of food allergy when it comes to taking care of our patients in a holistic way. Now, as we think about alpha-gal syndrome itself, I think there are a couple of salient points. The first is that adults are actually more likely to report experiencing anxiety around food allergy than pediatric patients. Certainly, children can have AGS, but it is often seen in adults. Adults are also more likely to report underestimating the severity of their allergies and panic attacks. So they're underestimating, they're minimizing, they're probably not seeking the help that they need. I also wanted to include a few quotes directly from patients that I hear about when we're taking care of these patients. They live in constant fear and feel like they have to be vigilant all the time. Several patients have told me eating is no longer pleasurable or fun. I've had other patients say, eating is a social activity and that has been taken away from me. I can't go to the church gathering or to the card game or to the local community organization. They feel that some of them feel that they have concerns around intimacy and sexuality being constrained because they're afraid of having a potential exposure that could cause a reaction. Equally, we know in the food allergy space that alcohol and exercise are cofactors for making allergic reactions worse. So there may be a temptation or an impetus to try to avoid those. Other patients will say the lack of transparent labeling, particularly around alpha-gal syndrome, can be crippling. The burdens of AGS, though, really extend beyond some of just those perhaps more consistent mental health concerns that we see across all of food allergy, and there are some unique aspects to alpha-gal syndrome. There's a great article from Sarah Zhang in The Atlantic recently titled "Another Reason to Hate Ticks." And in it, she reports and describes her interview with a farmer who had AGS and had difficulty caring for their animals and ultimately had to sell their farm. We know of soldiers who have alpha-gal syndrome and have difficulty with the meals that are ready to eat that they are sent with during deployments. We also know of several examples of chefs or restaurateurs who've had to basically sell their restaurant or change livelihood because they can't taste the food that they're preparing and don't feel comfortable serving it in that way. So there are some very specific burdens of alpha-gal syndrome that I think extend beyond the usual or more reported mental health burdens of food allergy in general. So how do we think about addressing this, right? And some of this is a work in progress. So we're starting to now think about mental health, mast cells, and tick bites. And what is that? Well, what's the association? So ticks are considered ectoparasites, and tick bites appear to activate mast cells. Mast cells are an allergy cell that is pretty readily found in the skin. And we think mast cells are basically a primordial cell that helps us avoid or expel parasites and may react to bites or stings. So scorpions or bees or wasps, they all can activate mast cells, and the mast cell is probably there to help protect us from the venom remnants of those stings or bites. But mast cells, unfortunately, can be bad actors. And mast cell activation or mast cell activation syndrome, which is commonly abbreviated MCAS, has been associated with anxiety. There's that anxiety again. Fatigue, brain fog, depression, and feelings of doom. Some of these you start to see and hear in the long hauler syndromes as well. So there does seem to be overlap. Fortunately, from the very generous Cohen Foundation and the Clinical Trials Network at Columbia University, we are working to launch a new pilot clinical trial that will be aimed at using mast cell-based therapies to try to minimize or perhaps even improve some of the symptoms that we've seen associated with tick bites in the longer term time points for kind of these long haul related issues. So in summary, I hope I've been able to convey that food allergy related mental health concerns largely include anxiety, panic, and fear, and that they are common. And it supports that the psychosocial burden of food allergies is a widespread concern. Unfortunately, despite a growing need, providers are really not routinely screening patients with food allergy or mental health concerns. There's also there's continuing and increasing unmet need for mental health awareness. And we also need specially trained professionals as part of the management for our patients with food allergy. So I appreciate your attention. I'll stop there and glad to answer any questions.
Great. Thank you so much, Dr. Cummins. And of course, I have lots of questions. And thank you for going over a very detailed and comprehensive presentation. You emphasized in your presentation that food labeling is critical to alleviating the constant fear and anxiety experienced by people with alpha-gal syndrome. A new bill was introduced in August by Representative Jeff Van Drew called the Alpha-Gal Allergen Inclusion Act. The bill proposes an amendment to the Federal Food, Drug, and Cosmetic Act that would add alpha-gal to the definition of, quote, major food allergen. This would enable labeling of alpha-gal similar to the way eggs, peanuts, shellfish, and other allergens are labeled. What are your thoughts on this proposed legislation, and do you see any limitations in that?
Well, I'm glad you brought that up. It is a point of emphasis for patients, for me as a provider. We really feel as though labeling when it comes to alpha-gal and therefore sort of helping people manage alpha-gal syndrome is a critical part of all this. The unfortunate news is that alpha-gal allergy seems to be probably the 10th most common allergy in the US right now. And then the 9 in front of it are all congressionally mandated for labeling. And to live right now in the US or anywhere for that matter with alpha-gal syndrome, you're really on your own to try to figure out, does this product or that product have a mammal ingredient? And manufacturers are difficult to get on the phone. They may not know the source of some of their derived products. So this is a huge step, a welcome step in the beginning of what we hope is transparent labeling for what may well be the 10th most common food allergen in the United States. So I think on behalf of patients who have alpha-gal syndrome, we really welcome this piece of legislation and hope that it begins to move forward to becoming a way that help increase safety for folks living with AGS.
No, thank you for that. And I think something you said I want to amplify is the transparency of that is so critical in the work that you're doing. So if someone suspects they or their dependent has alpha-gal syndrome, what steps should they really take?
Yeah, the blood test is really a good test. It may even border on being a great test. It's not a perfect test. We know we can miss some people, but this blood test is widely available. There are local and national labs that can run it. It is not affected by medicines save only one. So you don't have to be fasting. You can take your cholesterol medicine, your high blood pressure medicine. It unfortunately does not seem to diagnostically work very well for skin tests. So we really seem to need the blood test. Sometimes folks are used to going to the allergist and having skin tests done. Doesn't work as well for diagnosing alpha-gal syndrome. So we're focused more on the blood test. And we don't like it to be used without symptoms. And I say that because tick bites can cause people to have a false positive. So if you if you live in an area where the Lone Star tick is quite common and have a history of tick bites, you may test positive for alpha-gal IgE, but eat the food completely fine. We call this sensitization, and it's a problem or an issue within the field of allergy. So there are people who test positive for peanut, milk, and egg and eat those allergens and foods just fine. So the testing should not be a screening test, but should be used for basically people who have concerns because of symptoms. So we don't like it to just think, oh, I had a tick bite, I need to get that test. If you're not having any symptoms and you feel fine, no real reason in that scenario to run the alpha-gal blood test.
Great, thank you. And we talk about this, maybe there are clinicians or some providers that may not know as much as we'd like all of us to know. So any thoughts or words to share with patients that say their provider or clinician is being somewhat dismissive of what they're sharing with them?
Yeah, and unfortunately, we hear this from time to time. I think this is true when there's a new or emerging medical condition or disease, and that certainly can be true of AGS. I would encourage people to be patient with their providers. There are resources on the CDC website. We are working in partnership with the CDC to have a training module for providers, but it could be taken by patients or families to help increase awareness and knowledge. So there's more to come, but there certainly are resources available in multiple of the provider kind of not only textbooks, but like living websites where new information is available. So we continue to publish and try to get the word out. I often encourage patients and families, maybe print something that you found on the CDC website or from one of these reliable medical journals that, even if it's just the title, may help that provider realize that this is something perhaps they haven't diagnosed, but it's real and it's out there, and unfortunately seems to be increasing.
Thank you for that. And I know as we get ready to round out this sort of first part of our session, are there any parting words and thoughts you'd like to share with our listeners that key takeaway messages and the work that you're doing with alpha-gal syndrome?
Yeah, and I appreciate that. There are a couple of things that come to mind. The first is if you're having nighttime symptoms that are unexplained, and I'm thinking about hives, itching, redness, it would be good to try to track your diet, perhaps, and understand, can you make an association with eating beef or pork or lamb or venison, or maybe a dairy product like ice cream? There are not terribly many things that can happen to produce hives and itching late in the evening when you've been in bed, but food allergy is traditionally thought as something that happens, when you're at the table, you're at the restaurant. So I really encourage people to think about alpha-gal syndrome as a food allergy that kind of breaks the mold. So it is good to keep track of your symptoms. One thing that comes up a fair amount is alpha-gal syndrome can be inconsistent. So you could eat an offending food once and have a reaction, and you could eat that same food the following week and maybe not have a reaction. So it sometimes this inconsistency becomes a hallmark, actually, of alpha-gal syndrome. The other thing I will say is the newly appreciated portion of patients who have just gastrointestinal symptoms has really changed in my practice in many ways, because we're starting to think that there probably are people we are missing. So if you're suffering with middle of the night GI distress, nausea, vomiting, diarrhea, abdominal cramping. And if you live in an area where these Lone Star ticks can be found, it really may be something that you need to have that blood test run. And I think these days, with the increasing amount of focus on alpha-gal awareness, I'm hopeful that people can get that blood test done.
Great. Thank you so much, Scott, Dr. Cummins. So with that, thank you for everyone listening in. We are about to take a 15-minute break. So we are right here. We will start right back up at 3 o'clock. So we look forward to seeing you all back in 15 minutes. Thank you so much, and we'll see you shortly. Well, welcome back, everyone. We are wrapping up on our break and about to resume our meeting. It is my pleasure now to introduce Commander Grace Marks, Dr. Marks, who's with the Bacterial Diseases Branch, Division of Vector-Borne Diseases at the Centers for Disease Control and Prevention. Thank you so much for Dr. Marks for joining us, and the floor is yours.
Thank you so much. As mentioned, my name is Commander Grace Marks. I'm an internist and infectious disease physician and medical epidemiologist with CDC's Division of Vector-Borne Diseases. I'm very happy to be with you today to share an overview about a project that we've been working on for the past several years with the American Medical Association. So you've already heard a background on acute Lyme disease today by prior speakers, so I won't repeat that information today. Instead, I'll talk more about post-treatment Lyme disease syndrome. Lyme disease is caused by a bacterial infection and is treatable with several weeks of antibiotics. However, about 5 to 10% of patients experience symptoms of fatigue, pain, or cognitive problems at 6 months or longer after treatment, over and above the rate of these symptoms in the general population. Because these symptoms occur after treatment, the name for this diagnosis is post-treatment Lyme disease syndrome, or PTLDS. The cause of PTLDS is currently unknown, and effective treatment is also unknown. Multiple studies looking at additional antibiotics versus placebo for patients with PTLDS have not shown to have a lasting benefit. Hundreds of thousands of patients suffer from medically unexplained symptoms, which is incredibly difficult for patients who are living with the reality of being ill, sometimes with severe disability, without knowing the cause or how to get better. Some patients who never had a formal diagnosis of Lyme disease may wonder if their symptoms, which may be very similar to PTLDS symptoms of fatigue, pain, and brain fog, might also be from Lyme disease. But because they didn't have a prior clinical diagnosis of Lyme disease and haven't received recommended treatment for Lyme disease, they don't fit the criteria for PTLDS, and so the term chronic Lyme disease is sometimes used as a term to explain their illness. From the physician perspective, medically unexplained symptoms are difficult to face. Physicians are trained up in the biomedical model of education. We learn about diseases, their symptoms, the tests to diagnose symptoms, and then the treatments. So as an example, if a patient comes in with a sore throat, swollen lymph nodes, and a fever, physicians put together a list of possible diagnoses based on their medical knowledge. The patient might have strep throat, maybe mono from EBV, possibly acute HIV. And then based on that list of possible diagnoses, the clinician orders several tests to rule things in and rule things out. A physician's worth and place in the provider-patient relationship is based on this ability to take the list of symptoms that a patient describes and turn it into a diagnosable condition and then prescribe an effective treatment. So when a patient comes to clinic and they describe symptoms like brain fog, fatigue, chronic pain, the provider often really struggles to pull together a list of what often ends up being a very long list of possible diagnoses. And then they might struggle even more to find good tests to rule things in and out. And at the end of the day, the provider might not actually get to a diagnosis. So the provider is then confronted with this possibility that they may not be a good doctor, that they don't have worth in this doctor-patient relationship, even when in reality, the failure of a diagnosis might be because of current limited medical knowledge that doesn't yet have a way to make that diagnosis. The U.S. healthcare system presents another immense challenge for these patients. Insurance systems are set up to reimburse providers only when providers, quote, do something. So ordering a test, performing a procedure, prescribing a treatment. Insurance companies are terrible at reimbursing providers for taking the time to listen to patients, to think deeply about potential diagnoses, to search the literature, to advocate for their patients, maybe to link them to specialists or to others on the healthcare team. It's also incredibly frustrating for patients with complex illnesses to be allotted a brief 15-minute appointment slot. Networks sometimes also limit what physicians can prescribe or for what they can refer patients for. For example, sometimes networks will only pay for a certain number of therapy sessions. And in some areas, it's even difficult to find specialists within the insurance network. Meanwhile, celebrities and social media can reinforce misinformation about Lyme disease and infection-associated chronic illnesses. And the result is that many patients may ultimately experience medical wandering, where they're bounced around from specialty clinic to specialty clinic without a medical home to coordinate care or information and to provide them with a supportive environment. Multiple studies over the past 30 years have looked at patients who are referred to academic centers for evaluation of chronic Lyme disease, or CLD. And they've described the final diagnoses of these patients. Each column in this figure here on the slide represents data from one of these studies. The proportion of patients that were found to have Lyme disease is shown in the green bars at the bottom, which is about 20% across all studies. The purple bars represent patients that were diagnosed with PTLDS, post-treatment Lyme disease syndrome, which is a significant minority, as you can see here, about the 5 to 10% that I mentioned earlier. The blue bars represent patients where another diagnosis, completely different from Lyme disease, was found. And that's a lot of patients, about 30% overall here. And the gray bars at the top represent patients with medically unexplained symptoms, which is almost half, about 40%. Patients with unexplained symptoms may have a post-acute infection syndrome. Another term that's often used is infection-associated chronic illness. There are many infections that can cause prolonged symptoms, with Borrelia being just one, highlighted here with the red box. We don't have ways to test for these syndromes, and we don't have any specific treatments yet either. There's unfortunately also no evidence-based consensus to guide physicians in how to provide comprehensive care for these patients. Recognizing this unmet patient need, in 2021, the CDC and the American Medical Association began a collaboration through a cooperative agreement to develop a project with a single overarching goal: to improve care for patients with prolonged symptoms and concerns about Lyme disease. We had 3 primary aims. First, to identify the needs. We immersed ourselves in the literature. We also wanted to hear from physicians who see complex patients, and we wanted to know what works for them and what doesn't work. And for this, we conducted focus group discussions and in-depth interviews with both frontline and specialty clinicians who see patients with prolonged symptoms and concerns about Lyme disease. We then aimed to develop practical materials and resources for clinicians and patients. 3 themes emerged from the focus group discussions and interviews. First, there is a really critical need to validate patients' symptoms and to let the patient let them know that they are heard. Many patients feel rejected by physicians and by the medical establishment. Indeed, in some of these interviews and focus group discussions, we heard that in some clinical settings, patients with concerns about Lyme disease are routinely turned away and appointment requests are denied. Second, these visits take a lot of time, and visits can be overwhelming and emotionally exhausting. And third, clinicians identified a high overlap with other conditions, including fibromyalgia, chronic fatigue syndrome, and even long COVID. Clinicians expressed frustration by the inability with currently available diagnostic methodology to definitively diagnose these patients. This slide summarizes the work that we did through this collaboration. We presented data at the AMA interim meeting, received feedback from multiple physicians across specialty groups, and developed a web-based educational module and toolkit. A manuscript is also under development to share our findings. The module is now complete and available on the AMA Ed Hub and provides 1 category credit of CME. While there is a small section on Lyme disease for a general overview, it focuses on providing care for patients with prolonged symptoms. It goes through how to create a broad differential diagnosis and how to compile a multidisciplinary team and how to work with the patient and with other team members to create individualized care plans. The goal of the module is to educate clinicians on how to provide better care for patients, even when the cause of symptoms is not fully understood. The toolkit lives on the AMA website and includes resources for both physicians and patients. The QR code for the toolkit website is at the top right of the screen here, and it includes the CME module, along with interviews and videos and supplemental handouts, as well as tips for clinicians on motivational interviewing and setting expectations with collaborating clinicians. The toolkit also includes several handouts that clinicians can give their patients. This provides an objective way for patients to report their symptoms, what makes them feel better or worse, and also how different interventions affect their symptoms. Asking patients about, how to recall specific symptoms from, days that may be months in the past and how they felt in response to various treatment interventions is really unfair. And so these handouts are designed to allow patients to track in real time how they're doing and to empower them to put their responses to treatment in their own words. On the right is a goal tracker. Physicians should not be making assumptions about their patient's goals. Rather, these health goals should be defined by the patient and should be very specific. The toolkit also includes several resources for clinicians, including examples of how to employ motivational interviewing and how to manage differences of opinion in a respectful and compassionate way. There's also a sample referral letter to help grow a care team for patients. The toolkit that AMA developed covers the clinical approach in detail, but I wanted to outline just a few of the general principles here. First, during these clinical encounters, it's really important that the provider take a systematic approach to the patient evaluation. They need to actively listen to the patient's story and thoroughly explore the patient's timeline of their symptoms in response to any prior treatment. A comprehensive physical exam should always be part of the clinical encounter that is tailored to the patient's presenting symptoms. As mentioned, because many patients will ultimately be diagnosed with a condition other than Lyme disease, it's important for the clinician not to anchor prematurely to a particular diagnosis, but rather to systematically consider a broad differential diagnosis that's tailored to the patient's specific presenting symptoms and exam findings. The clinician should also always take the time to answer questions about Lyme disease, as well as to consider whether additional testing and perhaps additional treatment is clinically indicated. It's also important for providers to explain that they currently don't have all the answers and that a definitive diagnosis may not be possible. I can't overemphasize this, but maintaining diagnostic humility during these clinical encounters is so critical. We don't have all the answers yet in medicine. More research is needed to better understand the pathophysiology of prolonged symptoms and their association with infectious diseases. And I would argue most critically, more clinical research is necessary to identify effective treatment and supportive clinical approaches. Finally, building a multidisciplinary team that's coordinated by the primary care clinician can be really helpful to address specific patient concerns while supporting optimal patient health and recovery. So in summary, the AMA CDC toolkit is grounded in the clinical principles that are shown on the slide here. And we believe that this approach can help clinicians to provide excellent care for patients with prolonged symptoms and concerns about Lyme disease. So with that, I want to thank the organizers for the conference today to provide the opportunity to speak with you today. I also want to thank the patients and the clinicians who provided feedback on the toolkit and who will provide additional feedback to us, which we hope will continue to improve our future educational efforts. And at this time, I'd be happy to take any questions.
Great. Thank you so much, Dr. Marks. And I do have a few questions. So you noted 3 clear themes that emerged from the literature review, focus groups, conferences conducted for the AMA CDC project. One was that there was a high overlap with fibromyalgia, chronic fatigue syndrome, and long COVID. Can you describe how the toolkit supports clinicians in handling this overlap to achieve a viable treatment plan?
Yeah, I think first I'll just say that it's hard, right? I've mentioned several times during the presentation that there aren't really good available tests to diagnose these syndromes, many of these syndromes. The toolkit outlines a broad general approach that is designed to help clinicians engage effectively with patients and to tailor kind of a management and treatment plan for the patient based on their symptoms and to create a diagnostic and management approach. Because of the diversity of causes for prolonged symptoms, it wasn't possible to include a comprehensive diagnostic kind of evaluation algorithm in the toolkit. But instead, we encourage clinicians to reference existing clinical guidelines and also to enlist the help of specialist physicians and other clinical care members that are really guided in the clinical presentation that a patient may present with.
Great, thank you. And you talked about the toolkit. Can you expand on the resources provided in the toolkit? And does it really promote sort of that multidisciplinary approach?
Yeah, so, there are so many challenges in our current system to effectively create a multidisciplinary team. And as I mentioned, availability is very limited in many places in the United States. What we've tried to do in the toolkit is include a variety of resources that may be helpful. A couple of examples include a referral letter template. So this is really designed to encourage clinicians to briefly but comprehensively summarize the patient's presentation and what's been done so far in their clinical workup, and then to specify the particular question for which they are referring a patient forward to a specialist. And this can help to avoid specialists kind of turning patients away and saying it's really not my problem, which we do see happen occasionally, unfortunately. And in the module, we also encourage the clinician learner to again, think outside of the box in terms of who to engage, who to pull into a multidisciplinary team. And again, this looks very different depending on where you might be practicing. But things that you can consider include, and again, tailored to the individual patient, but options may include physical therapy, cognitive behavioral therapy, physiatry and rehab medicine specialists, neurology, psychology, and exercise therapy. So it really, again, needs to be individualized to the individual patient. And keeping their priorities in mind. Again, this comes back to engaging with the patient and really understanding what does health look like to them, because that's going to be very different depending on the individual patient.
Great, thank you. So when you talk about the toolkit, how does it factor in sort of from a clinician standpoint, possible co-infections or the possibility of co-infections?
Yeah, so the toolkit, again, doesn't go into great detail on any one particular clinical scenario because, again, it represents an immense diversity of clinical situations. I think what we try to do in the toolkit is to emphasize the importance of tailoring the comprehensive clinical and diagnostic evaluation to the individual patient. So regarding co-infections, that would really be tailored based on an individual patient's risk of exposure and their presenting clinical manifestations.
Great, thank you. So I have a whole lot of questions about the toolkit. So one last question. Another theme that emerged was that clinicians reported needing to have more time with patients, time with Lyme disease patients who are chronically ill. Does the toolkit address this at all or provide any thoughts around that?
This is so hard. And, I think physicians who practice in an academic setting may have more of the luxury of time compared to physicians that may be practicing in the private setting. Again, there's different healthcare settings can look so different in terms of what's possible. I think what we try to do in the toolkit is suggest a couple of different approaches that may be helpful for individual clinicians. One is to be sure that they're setting up expectations up front with patients, that these are complex medical issues that require time to unpack and thoroughly evaluate. So setting expectations up front, that could look something like, we have X number of minutes today. I know we won't have enough time during today's appointment, but what I'd really like to do is start today, hear from you about what brings you in today, and then set up a follow-up appointment where I can go into greater detail about the diagnostic workup and potential treatment approaches moving forward. So again, there may be more than one appointment that's required. Being sure that the patient is engaged, make sure that there's a follow-up plan that's well established before that patient walks out the door. I think that can be very helpful. There's also some new, codes that are available when you're going to billing codes to assign to appointments. So for complex medical issues, you can assign different billing codes that may help with that reimbursement piece. But a lot of it really comes down to communication and making sure that you and your patient are engaged in the plan moving forward.
Great. No, thank you for that. I think something that sounds like a best practice exemplar is when you said this is the start to this conversation. So really appreciate that. So before we move on to our next presenter, if there's sort of a takeaway message you'd like to share with our listeners, please share that with us now.
Yeah, thank you for that opportunity. I think, in terms of takeaways, I would just say, patients with prolonged symptoms due to Lyme disease usually get better over time without additional antibiotics, but it can take months to years to feel completely well for a minority of patients. And then also prolonged or recurring symptoms, no matter the cause, can lead to considerable suffering. And it's important that healthcare providers support patients and their families as they learn how to manage those symptoms. Thanks again.
Great. Thank you so much. All right. As we move on, as we start to talk about researcher perspectives, I am happy to have Dr. Sherry Marvel join us. And Dr. Marvel, the floor is yours. She's Associate Professor of Neurology and Psychiatry at Johns Hopkins University School of Medicine.
Hey, thank you for having me. Let me see if I can get my slides and everything to work for you. Okay, how does that look? Is that going to work for
Looks great.
Okay, thank you.
Sure.
So I'm happy to talk today, happy to be invited and share my work. A lot of this is not published yet, and we're working on publishing it, but I do want to throw that caveat out there. It has not been peer reviewed and vetted, but I think it's pretty compelling stuff and I wanted to share. I am a cognitive neuroscientist, which means I don't treat patients. I'm a PhD, but I'm very interested in how the brain works and was not interested at all in neuroimmunology and infectious disease until I actually came down with Lyme disease myself, and then was fascinated by some of the effects it was having, not only on my body and pain that I was experiencing, but also, the cognitive effects. So I was very fortunate to get better after one round of treatment. So I'll just jump right in, especially in the interest of time. I have Lyme disease is well known to this group, so I just have this introductory slide just to orient us to being all on the same page. Post-treatment Lyme disease is what I'm going to focus on. These are, for the most part, these are people who were treated with a round of antibiotics, but went on to still develop persistent symptoms after that, which affects 10 to 20% of people who get infected. And cognitive complaints are really common among people who have PTLD and also acute Lyme. And the question we had was, as a cognitive neuroscientist, I was just asking, are brain changes associated with this illness? What's happening? I didn't see that there was much regular reporting in the literature about what was happening to the brain. And I was pretty confident something was happening to the brain. Oops. Okay. I'm going to go over 3 studies, and I'm going to explain some of my imaging methods and the tasks that we use, and then I'm going to jump right into what we found. Oops. Sorry. All right. It is important that people understand what functional magnetic resonance imaging is, because if you're going to, I'm going to show you a lot of data, so you have to understand what I'm showing you. And a lot of people think MRI is all the same. Get an MRI. It's not all the same. And what I'm focusing on is functional, meaning we're looking at how the brain is responding, its activity, not a static structural image. It's actually what's happening while people are doing cognitive tasks or motor tasks, depending on your study. What happens is blood flows to the brain in different brain regions because it's delivering oxygen to where it's needed. So if I'm, just like in the body, if I'm doing some, doing barbells, bicep curls, a lot of blood's going to my biceps because that's the muscle that's active. The same thing happens in the brain. If you're doing a really cognitive executive load task, your frontal lobe's very active, blood's rushing to the frontal lobe to deliver nutrients and oxygen because of all the energy that's needed there. And it's this oxygenated blood that rushes in, oxygen gets taken up. The MRI is measuring oxygenated versus deoxygenated blood. And that's where we get our signal. And this we use as a proxy for what we think is neuronal activity. And these signals change, they, depending on what you're doing, it might be the frontal lobe, it might be the motor cortex after that. So as the blood's moving around, the MRI signal is changing. And in research, we look at this change and we measure these changes in one aspect of a task versus another. So we basically subtract one. We say, what's going on in the brain while they're doing, while they're counting backwards versus when they're counting forwards, let's say. And after using some software and a lot of math, we can make these pretty pictures where we see the brain kind of lighting up. These areas in red on the top picture would be areas that are active. That blue line indicates if we were to split the brain apart right there and we looked at the picture at the bottom, we can see inside the brain and see what brain areas are being activated. Now, I do want to mention that most of the MRI signals are found in gray matter. I mean, pretty much exclusively. And this becomes important later. So I do want to spend a second on this. The gray matter is mainly on the outside of the brain with white matter on the interior. On the right, in the middle picture, you can see that there's a lot of, all the activations are in fact in the gray matter. And on the far right, you see pictures of electrical wire. And I like to give this analogy because it's a lot like an axon and a neuron, where the insulation you see on this electrical wire represents the white matter. White matter is insulation around an axon. As the electrical signal travels down an axon, it is insulated so that it doesn't lose its speed, just like an electrical wire. At the end of this electrical wire, the insulation's missing, it's stripped. That's basically what happens with our own neurons. At the end, The gray matter is basically the axon with the insulation stripped off. And that's where all the business happens. That's where the neuron talks to another neuron, and a lot of energy is needed there. So blood goes there, and that's where we pick up our MRI signal. So I want to put a pin on this point. We're not supposed to pick up MRI signal in the white matter, because I'm going to come back to that. And the cognitive task that we're using is something called verbal working memory. Frankly, it was easy for me to use this test in my research because I had already been using it in some of my other studies before I got into Lyme research. So it was kind of canned and ready to go. But in my experience and in what people were talking about with Lyme disease, verbal working memory is a big part of some of the problems that we have, which is verbal working memory is like if you're reading and have to hold something in mind to follow instructions, listening to your GPS give you directions, even if you're learning new words and things like a foreign language, it's really hard to keep that in mind, and you can get distracted and lose your train of thought very easily. So this was what we wanted to test in the scanner. I'm not going to go into the details of how the test is for time, but I'm always happy to talk about that and how it's run if people had questions about that at the end. So our first study is this one was published, and we looked at PTLD participants. We just had 12 of them in the scanner. They had been sick for about 2.5 years versus healthy controls. We did the working memory task. We assessed clinical variables to correlate with our fMRI findings. And the first thing that we found was there were some differences between the groups. So what you're seeing here in the upper left is the front of the brain. And as you read left to right and go down the screen, you're taking slices to the back of the brain. If we look at what we compare the groups, which group had more activity, the PTLD group is shown in red when the PTLD group shows more activity in different brain regions than controls. So just to remind you, if they're showing equal amounts of activity, they cancel each other out. So we're not seeing what's going on in both groups if they're the exact same and they cancel each other out. This is above and beyond the differences. And we see a lot of red. We see a lot of red towards the frontal lobe, front of the brain. This really just suggested that to us that the PTLD group had to work harder to complete the working memory task. And that's kind of what we expected, frankly, and we weren't surprised. And a lot of extra work in the frontal lobe, not surprising. We wanted to be able to say, okay, there it is. What people are complaining about, they have to work extra hard to get the job done. They can get the job done, by the way. In this study, the accuracy was fine in our PTLD patients, but they had to work harder to get there. What did stick out to us, though, that I thought was strange, and these blue arrows show 3 brain regions where these activations were primarily in white matter. And maybe with an untrained eye, that may not have popped out to you, but if we look at this information on a different segmentation template, you can see that those 3 brain areas were pretty much exclusively in white matter. And this was very strange. This was not something that I had seen in my, I've been doing brain imaging from a functional imaging for almost 20 years. I hadn't seen this before. And then we took those regions and we kind of carved them out, got the signal from within each of those 3 regions. And we said, well, let's correlate them with their symptoms. And we're looking at post-Lyme questionnaire of symptoms, which is a clinical questionnaire of symptoms based on that was developed specifically for Lyme disease. And higher numbers mean that you have more symptoms. So our first thought was, oh, cool, there's actually a relationship between these strange white matter activations and symptoms. But then it got weirder because it was showing that the higher the symptoms, the less MRI signal we were getting. As that MRI signal increased, this unusual white matter signal increased, the symptoms decreased. So this was actually, white matter change was associated with fewer symptoms, not more. And that was, of course, we didn't know what to do with that. So that kind of segued into this next study that I'm about to tell you about, which is in preparation. It was actually ongoing at the same time as the other study, but because we had a slightly different design, it's been taking longer. But the main questions, now that we know the first study, when do these white matter changes show up? The other study, the people were 2.5 years out. Does it happen soon after infection? Does it take several months to appear? Maybe it takes years. So in this study, we have 20 people that were tested soon after they were infected and got their treatment, and we have 19 healthy controls. They were tested after their antibiotics, their first round, and then we saw them again 6 months later. And it kind of ended there. We didn't have the luxury of going beyond 6 months. Now, because though we knew at 6 months what their outcomes were, we were able to divide up the groups into two. Those who still had symptoms of PTLD, which I'm going to call SPTLD with a little s, and return to health and healthy controls. And you can see that the SPTLD group and the return to health group were almost even. So we got lucky there. And we do the MRI, we do the verbal working memory test. I want to point out, although we use the post-Lyme symptom questionnaire, questionnaire of symptoms, we also use an SF-36. The reason why I'm pointing it out here, I like the general health score on this, and I just want to note, higher symptoms on this scale mean better. And that's the opposite for all the other scales we use. I'll just get right to the imaging. We did this study in the return to health. The orientation of this, by the way, is a little different. Instead of, the slices go through the brain in what we call axial slices. So at the top left would be a slice through the top of the head, going all the way down through to the chin area at the bottom right. And what we're seeing here was, if you look at this, you don't have to know anything about anything, just there's a lot of red. Unless you're colorblind, I'm telling you, there's a lot of red here. And what that means is there was a lot of activity in the return to health, more above and beyond the healthy controls at baseline soon after infection. In blue, and I had to circle it because you can barely see it, that's what was active in the return to health more than controls 6 months later. So all that activity that was going on in the return to health group in the beginning, before we knew they were returned to health, they didn't know they were going to return to health. We didn't know that either, but we can retrospectively divide them up and look at them separately. These people had a lot of brain activity early on. It basically normalized by 6 months. There was no reverse activity. Healthy controls showed no brain region that was more active than the return to health group. And yet the return to health group did just fine on the test. When we look at the SPTLD group, it was pretty stunning because they showed none of this hyperactivity. They look like controls, and that's a strange thing, but they're just not showing much. There's one activation, -16, -20 slices down in the bottom right in red. One little activation at baseline that was more than controls. One little activation at 6 months that was more than controls. And that's it. So that's sort of the takeaway with this is that there was a lot of activity here in the return to health group that we don't see in the SPTLD group. And what I didn't mention, but was also equally kind of stunning to me as a cognitive neuroscientist, was that most of the activations in the return to health were in white matter. A lot were in gray, but it was 64%, more than half. Just a very strange thing. This is what happens. This is what the brain activity looks like relative to their symptoms and health outcomes. This is a lot to take in, so I just want to break this down for you. What we're seeing here is the return to health on the far left, return to health, and I divide it up into gray and white matter activations, but they show the same relationship with SF-36. It's all in red. What does red mean? A positive correlation. The more brain activity they showed, the higher their SF-36 scores. Remember, higher means better. So the more brain activity these people are showing soon after infection, the better they feel. And we also have so other surveys besides the SF-30. Oh, one point that I do want to make about the SF-36 was that most of the best and strongest correlations are with the non-physical, the social function, vitality, energy, and general health, not body pain, not physical function. And when we look at other measures, they're more blue, and that's because their scales are reversed. So lower numbers is better. Again, brain regions were correlating with better outcomes in terms of fewer Lyme-related symptoms and less fatigue. The BDI is the Beck Depression Inventory. Didn't see strong correlations there or with pain. You notice this row here looks different than the stuff above it. This is the SPTLD group, and they show the opposite. At baseline, soon after after one round of treatment, they have one little brain activation. Remember, they didn't have much, but it looks completely opposite from the return to health. This is at baseline, and we didn't know what their outcomes were going to be. They didn't know either. So these are brain areas that are going on in relationships that we didn't know was going to happen until we looked at the data, 6 months later. Keeping with PTLD, 6 months later, they actually start to shift. They start to look more like the return to health group. And then the return to health group 6 months later, in and of itself, I'm not sure what to make of this part of the data yet. I'm still trying to think about it, but they seem to be reversing from themselves as well. So this is a lot to take in. So the takeaway from study 2 is that we have robust brain activity is seen early following infection, but only in the return to health group. Most of the early brain activity is in white matter. That's very strange. At 6 months, most of this brain activity is normalized. And there's a relationship between the brain activity and the health outcomes, but they are completely opposite between the two groups. If you're going to return to health, you show a lot of activity early on. It's related to positive symptoms. And in the SPTLD group, you show less brain activity, and this is related to feeling poor. I should mention that both groups had equivalent symptom ratings at baseline. Okay. So then one question that's still lingering here is, what's the white matter activity telling us? And I'm going to just really touch on this third study, which is even more preliminary. It's not even, we haven't even really, we've presented an abstract. We're about to present an abstract on it. That's how new it is. But brain activity during working memory, we looked at some of the same measures, but this time we added a blood draw to look at neurological biomarkers. And there were 18 people per group, very well matched, but these are PTLD. They had been infected for about 2.5 years. And this is what the messy brain activity looks like for me on a daily basis. So this is what I just want to talk about this for a second, but in red are the brain areas activated in the control group, blue in the PTLD group. What I'm showing you is, believe it or not, no group differences. So these PTLD patients, if it statistically look no different from controls, and I could, and to show you that it would just look blank. So I didn't, but what I want to show you is within each group, there's a lot of activity. So I can carve out those brain areas within each group and correlate that with symptoms to see how they relate. Correlate that with any variables, including the blood work, to see how they relate. And we looked at 98 neurological markers, and there was one and only one that correlated with better outcomes, similar to what the MRI data was showing us, and that's called GFAP. And I'll get into what GFAP is in a second, but what I want to also point out is it was not on our radar at first because there was no group difference in GFAP. The GFAP levels between the two groups was normal, but it's only when we look at the correlations within that things start to come out. What you see on the x-axis here is the GFAP levels. In red are the PTLD group, yellow the controls. And you can see that the GFAP group correlates positively. The higher the GFAP, the higher their SF-36 general health score, the better they feel. Then we see, if you look on the x-axis here, it's the MRI signal. I picked one of the ROI, one of the regions of interest, but the higher that MRI signal, the higher the SF-36, the better they feel. And then this bottom slide scatter plot shows MRI signal on the x-axis, GFAP levels on the y. The higher that MRI signal, the higher the GFAP level. And so it's full circle, full triangle with the correlations. The bottom slide is particularly interesting because remember, MRI signals did not differ. GFAP levels did not differ. It's the relationship within the groups that matters. And it's only this relationship seen in the patient group, not there in healthy controls. GFAP is a protein that reflects astrocytic activity. Astrocytes are other cells in the brain that support neurons. They provide energy. They provide blood to the neurons. They make up part of the blood-brain barrier. So they're really important. They do respond to injury. They can be helpful, but like anything helpful, too much can be harmful. So this has actually become a player in Alzheimer's disease. People are looking at this, but that's usually because the GFAP levels are unusually high. Here, they're normal. So maybe a moderate increase or mobilization of astrocytes is a good thing. And that's pretty much where my story ends at this point. So the overall takeaways: brain changes begin soon after Borrelia burgdorferi infection. Early, robust changes are associated with a faster return to health. Brain changes affect white matter more than gray matter. That's highly unusual. And I'm now starting to think astrocytes might be a key part of this healthy response, which is going to require much more investigation to figure that out. And I'll leave at this point with the research team. I do want to acknowledge it takes a lot of people, and all of my patients come from John Alcott's group, who are in his SLICE studies. So I do want to point that out, and we do have some funding that has made this possible. The first two studies that I showed you were from private donations, so it's really hard to get this kind of research up and running and going, getting off the ground. And I currently am supported by NIH, which is great, but that's the next chapter. So I just want to leave it there. Thank you very much. I can take some questions.
Great. Thank you so much, Dr. Marvel. And I really appreciate how with your studies, you left with those takeaway messages. Really appreciate that. We're right here on target. One question I do have for you, can you clarify or at least reiterate what happens to the brain when a patient has brain fog?
Well, I think that actually is not well known. If I were to speculate based on what I hear from stories, what I think is happening is that it's some sort of processing speed, the brain's slowing down. One way the brain may slow down is if the insulation, I talked about insulation around neurons, just like electrical wire has insulation, it helps keep that electrical signal running smooth. If that insulation is compromised, then the electrical signal could slow down. And to me, and that could be anywhere in the brain. So it's not like when people have brain fog, you can say, oh, look, the hippocampus is affected and that's it. Or the frontal lobe has a little, hemorrhage here. That's not it. It's got to be more diffuse. And that makes a lot of sense if the insulation is somehow thinning or getting disrupted. I don't have evidence of that here, but that's sort of a speculation. But I don't think anybody's shown like the marker for brain fog. It's more nebulous.
Great. Okay. Thank you for that. I do have another question.
Absolutely.
Can you elaborate on how the findings from your studies might translate into clinical settings?
If I were to guess, because I'm not a clinician, but I feel like there are a couple things. I think if I continue along this path, it's prognostic. I'm getting to the point where I can almost see who's going to have symptoms down the road and who's not based on what they look like at our first scans. And our study with NIH right now, we just started this summer with acute Lyme, and I can already see it's like there are a couple people, there are like 4 people who look good and 4 people who are at risk, and I'm curious to see what they're going to look like when they come back. But I think in the short term, what I would say in the clinic is these brain changes are real. They're quantitative, objective measures that I'm seeing here. This is not something that people can subjectively, report and have a bias. This is not something, you can't control your brain activity. You can't control GFAP levels in the blood. So for any doubters in the clinic who might think, this is a real thing, that I hope not so much for the clinicians, but the patients, it helps provide validation as well.
Great. Thank you for that. And I do, with my last sort of comment and question to you before we move on to our next researcher, like I said, you listed sort of the takeaways from your studies, but if there was a takeaway message for our listeners, what would that be from your presentation here?
Oh, wow. I think that the brain changes are happening, and it's almost, I think one thing that we're not maybe doing enough of is studying people who return to health as closely as we should be, because I think what's happening is it's what your brain doesn't do that could lead to some of these symptoms more so than what the brain does. I think there's a healthy response that I'm picking up on, and there's a lack of this response that leads to persistent symptoms. So I think that would be my takeaway, is that we need to understand more about the people or the mechanisms, for the healthy mechanisms, so we can better understand what's not happening. And I would also just say to the listeners who are patients is that I know it seems slow and treatments are not coming as fast as they should be, but as researchers, we are trying, and we are making some progress, and hopefully that'll pick up some momentum in the next few years with more funding opportunities.
Great. So thank you, Dr. Marvel.
Sure. Thank
Appreciate
you.
your presentation, and we will now move on to our next presenter. Great. Well, welcome. And our next presenter, researcher, is Dr. Saravanan Thangamani, and we'll be presenting on the Powassan encephalitis, emerging tick-borne diseases of human health concern. So welcome, Dr. Thangamani.
Hi, good afternoon, everyone, or good evening. Thanks for the invite, and I think I'm going to be the odd person talking about Powassan here, something other than Lyme disease, and I'm also a researcher with very little human clinical research experience. But I want to kind of highlight an emerging tick-borne disease of human health concern in the United States, which is the Powassan encephalitis. So I want to start straight away with the Powassan virus introduction. It's a flavivirus. It is first isolated in 1958 from the brain of a young boy who died of encephalitis in Powassan, Ontario, Canada. It's very closely related to tick-borne encephalitis virus circulating in Europe, Russia, China, and Japan. Originally, when the discoverers isolated the virus in 1958, they implicated Ixodes cookii, or the groundhog tick, as the primary vector. However, in 1996, researchers from Harvard were able to isolate a genetic variant of Powassan virus from the ticks collected in Connecticut and Massachusetts. When they did a genetic analysis on these particular virus isolated from the deer ticks, they found that it is genetically very close related to Powassan virus. So they called it as the lineage 2 of the Powassan virus, also called as deer tick virus. And upon a Powassan virus infected tick bite, the incubation period for Powassan virus infection, establishment of productive infection is about 1 to 5 week period. And initially, 60%, I mean, some reports tell that, I don't know how far it's accurate or not, that's why I put approximate, 60% of the cases are either asymptomatic or end up getting febrile illness, like flu-like illness, fever, sore throat, drowsiness, and headache. And that's normally one would get after a week after a virus infection or a virus infected tick bites. And some unlucky people, they will end up getting neuroinvasive disease such as meningitis, encephalitis, meningoencephalitis, or acute flaccid paralysis. And once someone gets into the neuroinvasive disease condition, there is a 15% chance of succumbing to the disease. And 50% of the survivors of the neuroinvasive disease will have long-term neurological sequelae, such as cognitive difficulties, memory loss, concentration, pertinent headaches, muscle weakness, or paralysis. And so this is kind of a rare, but it's a fatal disease. And 50% of the survivors of the neuroinvasive disease can have lifelong consequences, neurological sequelae consequences. And I just want to show how impactful this particular disease is that this is an MRI of a fatal case of Powassan encephalitis on admission, and 8 days after showing severe inflammation in the midbrain and cerebellum area, the patient lost consciousness and the capacity for independent respiration 2 days after admission and died on day 13. So Powassan encephalitis cases are typically characterized by perivascular focal parenchymal infiltration, composed largely of lymphocytes and monocytes. Widespread destruction of neuronal cells has also been reported in the large motor neurons of the brainstem, spinal anterior horn, cerebellum, basal ganglia, and thalamus. And during the first week, it is possible to diagnose the virus infection by virus isolation or PCR in the blood, but 99% of the time, no one ends up in the hospital after a week post tick bite, because oftentimes in clinic, I think when someone comes with an acute febrile illness, Powassan virus is probably the least thing on their mind. But most often, IgMs or IgGs are actually used as a benchmark for diagnostic assay platform. And in some cases, cerebrospinal fluid is collected and sent to the state health laboratories and CDC for virus isolation, serology, and PCR sequencing. As per the CDC guidelines, the patient sample should be positive for a Powassan virus IgM in the CSF, followed by PRNT assay, or it should be negative for IgM to other endemic viruses circulating in the area of the patient coming from. Powassan virus case, as I said, it's very rare. However, it's fatal. Here is an epidemiology data that I downloaded from CDC that between 2004 and 2022, there are 288 cases reported to CDC. Of that, 267 are neuroinvasive cases, and of that, 35% of the humans succumb to the disease. I must tell that these are the reported cases, so quote unquote reported. Many of the cases are either asymptomatic or goes unnoticed during the acute febrile illness. Retrospective studies done on retrospective serological studies done on human samples clearly tells that approximately 20% of the Lyme disease patients they are serologically positive for Powassan virus, which means that majority of the cases of Powassan virus infections they are not reported to CDC or not diagnosed in a clinical setting. And over the years, the number of cases has increased. Right now, on an average, we are getting there are about 40 cases per year are reported to CDC. So there is a growing trend in the number of human cases. This could be attributed to multiple factors. One could be the geographic expansion of the ticks. The second one is our new methodologies and better methodologies to diagnose Powassan virus infection, and also the knowledge and awareness of Powassan virus in the hospital setting and in healthcare setting, primarily in the northeastern United States. And between Powassan virus, the Powassan virus infections are primarily reported in kids under 18 and also humans between 60 and above. So 60 and above. So the younger population and the older population are the primary age group that are susceptible to the infection. And between males and females, there is a propensity that there are more males are actually virus than females, which we don't know the reason why, but it's an interesting data to actually emphasize. And I must emphasize the geographic expansion. I think I want to highlight here is that although the original Powassan virus case was reported in 1958 from Canada, in the United States, the very first human case was reported in 1970 from New Jersey. However, 2-3 decades after that, the virus has exploded throughout the northeastern United States and the Greater Lakes region. Now, we are getting cases even in southern United States as well. And this kind of nicely overlaps with the deer tick virus habitat. So what we think, or what we speculating, is that in the next 5 years or so, we will see more human cases coming from, reported from the southern United States as well. And I want to kind of highlight some of our own data to emphasize that even within in the tick population, the number of ticks continues to increase. So when we started our surveillance program, without going into the details for the sake of the time, if anyone is interested in our surveillance program, you can find it at nyticks.org. When we started our program, 0.25% of the deer ticks were positive for Powassan virus. As you can see, the year goes by, we are now sitting at nearly 3% of the ticks that we tested or encountered by humans are actually positive for Powassan virus. So it is a clear indication that the rate of prevalence of Powassan virus in the ticks are increasing, and we don't know the reason why. And that is one of the research that lab is doing to understand what are the factors that actually influence the emergence of Powassan virus in New York. In addition to that, non-traditional vectors are also playing a role in the expansion and dissemination and transmission of Powassan virus, both in laboratories and in the field. Dog ticks and Lone Star ticks and Longhorn ticks have been implicated to be a competent vectors to transmit Powassan virus. So I think this will only add more trouble to what is already becoming a major problem in the United States. And clinical care, unfortunately, there are no FDA-approved vaccine or specific therapy. For Powassan cases requiring hospitalization, supportive care is provided, and it often involves respiratory support, intravenous fluids, and reducing cerebral edema. There is too little evidence to support or refute the use of high-dose steroids or IVIG. Minimizing exposure to ticks is the best preventive measure for Powassan virus infection. It's unfortunate. But I want to kind of highlight some of the key points that, some of the things that we have been doing, just to emphasize how epidemiologically relevant the data that I'm presenting in the next few slides. I know earlier I mentioned that there are two lineages of Powassan virus, lineage 1 and lineage 2. And we know from the, serologically, these two viruses are indistinguishable in a clinical setting, but we were very curious to know, do they cause similar disease in humans? Of course, we can't do this on humans, so we decided to do this on a mouse model to understand, does these two viruses cause similar clinical outcome? I'm not sure why the image is kind of misaligned here, but the bottom line is that I want to kind of focus your attention to the left panel here, where we have inoculated the diatic virus to one group of mice, and then Powassan virus to the another group of mice. And then we actually monitor their health and clinical outcome over a period of time until they become moribund, and we have to, shut down the study at the time. And when we calculated the mean survival time, both diatic virus and Powassan virus, they pretty much survived the same time. So there was nothing, nothing exciting for us. However, when we looked into the clinical scores, or what is the reason for their death, what is the reason why they succumb to the disease, is what that actually got excited us. So diatic virus, the primary reason we have to euthanize the mice or weight loss and seizure. However, for the Powassan virus, it was paralysis and paresis. So this was pretty exciting for us. This was giving the first clear indication that these two viruses, though the clinical endpoint is the same, how they reach the clinical endpoint is different. So how the virus is actually invading the neuronal cells, invading the central nervous system, is probably different. So that allowed us to that made us to kind of pursue this study a little bit deeper. When we looked the viral titer in the brain and lymph node, definitely there was more virus, more diatic virus in the brain compared to the Powassan virus. So it was very clear that, there is a differential infection outcome coming between these diatic virus and Powassan virus. And when we did, brain sections, and then we consulted with a histopathologist to score the severity of the lesions, and, what kind of lesions we are getting in different regions of the brain that are listed here. It is very clear that in hypothalamus, hippocampus and thalamus, diatic virus infection caused severe microscopic lesions compared to Powassan virus that is highlighted here. So there is definitely a differential infection outcome happening in the brain. Then when we want to look at the viral tropism, like where does the virus goes in the different parts of the brain, so we actually stained for the virus, and we also stained for an inflammation marker, which is CD11B. And you can clearly see the dietic virus, most of the virus is homogeneously presented throughout, but for the cerebellum area, for the Powassan virus, it's primarily infected in the cerebellum area. So we again consulted with the histopathologist to actually score these sections, and then it was very clear that dietic virus prefers to infect cerebral cortex, hippocampus, and thalamus, while Powassan virus prefers to infect cerebellum. It doesn't mean that these viruses are not infecting other regions of the brain, but they preferentially infect in the regions that are highlighted either in the purple and the green. The green ones refers to dietic virus, the purple one refers to the Powassan virus. So it's very clear from these studies that there is a viral tropism in the brain. These viruses prefer to infect different regions. And I must tell that slowly, if you follow the trend, this will give us a reason that the cerebellum brainstem are positive for Powassan virus that actually correlated to the clinical outcome where we saw paralysis. And we were interested in, because we observed paralysis in the Powassan virus mice, so we want to look at the spinal cord to see, what do we see? What is the status of the neurons there? So we actually, although I show only for the cervical spinal cords, we actually looked at cervical, thoracic, and lumbar spine. And you can clearly say this is the normal healthy neurons that are highlighted in the black arrow marks. And in dietic virus, we see healthy neurons. But however, in Powassan virus, we start to see degenerative neurons, which are highlighted by the black marks. In addition to that, you can actually see at the top right panel for the Powassan, the meninges are inflamed. It's very clearly, you can see the meninges inflamed compared to the dietic virus. We again actually stained for the virus. We wanted to see where does the virus locate. Are they in the lumbar or thoracic cervical region? We saw mild infection dietic virus, which was expected, and then for the Powassan virus, we saw a lot of virus infecting neurons in the cervical spinal cord, and then a little bit of less in the thoracic and lumbar. So it was very clear that the cerebellum is infected in the brain, brainstem is infected, and then the cervical spinal cord is infected as well. So that clearly kind of articulated that at that stage of our study, all the viruses was primarily in the cerebellum, brainstem, and the cervical spinal cord for the Powassan virus. Then this is an amplified version of the same thing that I showed earlier. So here is a dietic virus. These neurons. So these are neurons that are highlighted in red, and then infected neuron is highlighted in the black one. Those neurons are degenerating, but we saw more degenerating neurons in Powassan virus, and you can appreciate the amount of virus infected cells in the Powassan virus cervical spinal cord. So we concluded that there is these two viruses, they have distinct modes of neuroinvasion into central nervous system that ultimately dictates the pathogenesis of these two clinically important emerging viruses. I know at the end of the day, the clinical outcome is the same. However, for us as researchers, we are very interested in seeing how the virus is actually traversing from the tick bite site all the way to the brain. This will allow us to develop novel countermeasures, probably antivirals or therapy, based on what virus is infecting the human and the route they take it to the brain. And with that, I want to kind of highlight the common theme of today's presentation is the Lyme disease and Borrelia burgdorferi. And so I want to kind of highlight one part of the work that my lab is doing, which is the co-infections of Borrelia and Powassan. How does it actually impact the clinical outcome of both Lyme disease and also Powassan encephalitis? We all know that the deer tick is the common vector for Borrelia and also for Powassan. In addition to Borrelia and Powassan, the deer ticks transmit multiple other pathogens that cause disease, Anaplasma, Biamoto, Ehrlichiosis, and babesiosis. So we want to take advantage of the timeline of pathogen transmission as listed here. Powassan virus is delivered to the humans as soon as the tick latches on the human. However, Anaplasma and Borrelia, they typically take about 2 days to 3 days to actually enter the human skin. Obviously, there are exceptional cases, but majority of them takes a little bit of time. That is due to the biology of Borrelia that stays in the midgut until the ticks start to acquire the blood. When the ticks acquire the blood, the Borrelia then replicates in the midgut, slowly gets out of the midgut, and then goes to the salivary gland, and then gets delivered into the human skin. So for this biological process to happen, for the Borrelia to move from midgut to the salivary gland, it takes about 24 to 48 hours. And that's the reason why there is a delay in Borrelia transmission. So what we are hypothesizing is that when a co-infected tick is feeding on the skin of the human, it delivers the virus first. And within day 3 or 4 in mouse model, the virus enters the brain, which means that it breaches the blood-brain barrier. So when the blood-brain barrier is breached, that's when the Borrelia is entering to the human skin. So what we are hypothesizing is that now the Borrelia has a safe passage all the way to the brain very quickly, which means that this could be a reason why neuroborreliosis is happening. So this is a hypothesis. We are still working on it to understand if co-infection with Powassan virus could be a causative reason, could be the reason for neuroborreliosis. We don't know yet, but we are kind of investigating that. So what I can actually share today is data that we did with the ticks. I'm sorry for this image that is rather little, but I can summarize this whole study and tell that if in a co-infected tick, Powassan virus was replicating at higher titers, and also Powassan virus left the midgut and reached the salivary glands much faster than a singly infected tick, and there were more virus in the salivary gland of a co-infected tick. If there are more virus in the salivary gland of an infected tick, it will obviously deposit more virus at the human skin when the tick is feeding, which means that it can exacerbate the Powassan virus infection and dissemination, leading to even worse clinical outcomes. So that's what we are hypothesizing. One of my grad students is currently investigating this co-infection phenomenon in mouse. Hopefully the next time I will have more information to share. However, I want to kind of finish up the talk with the one of the study that we are doing, and I will try to highlight the rationale why we are studying it. So when we were doing this study, we realized that we are using Borrelia and the Powassan virus that are almost 40 years old. That was laboratory adapted for such a long period of time. So we decided that is it really epidemiologically relevant that we are using a 40-year-old strain? We all know from SARS that viruses mutate a lot, and what the strain that was that infected humans in 2020 is not the same one that is infecting humans now. So we know that epidemiologic relevant strains, investigating the epidemiologic relevant strains are highly, highly important. So we decided to actually isolate currently emerging circulating Borrelia burgdorferi and Powassan virus isolation. Luckily, my lab is doing a surveillance program, so we are able to actually tap into those bioarchives to isolate both Borrelia and Powassan. And we have developed our own methods in the lab, how to isolate viruses from the field collected ticks. And so far, we have successfully cultured 41 different isolates from all different regions of the New York State. And I can give some highlights of why I'm emphasizing it's very important that we should work with circulating emergent strains is that, so when we sequence the entire virus genome, I'm kind of showing only the DTIC virus samples here. It's very clear that these viruses, they have genetic differences and they form different branching, which means that this particular branch of viruses will behave differently than the other viruses that are in this branch. So we were starting to see some differences genetically. So if there are any genetic differences, obviously it will result in phenotypic difference as well. And the other thing that we found is that viruses isolated from ticks collected in lower Hudson Valley are different than the ticks collected from the Onondaga County where I'm from. So it was very clear that these viruses are geographically separated as well. So I can highlight some of the studies that we did in vitro, and we actually wanted to see how does the virus replicate in a cultured dish. So this is the virus on the left, Powassan L2, that's I'm calling the DTIC, but that's the parental strain that everybody in the United States is working on, which is 40 plus years old. But the other ones are the isolated viruses from my lab. You can see that the virus is growing, the virus growth morphology in the cell culture dish is completely different. Some of them are small, pinprick size, some of them are larger. So it definitely tells that these viruses are not the same. They infect the cells at different rate of kinetics. And when this is another way to look at the infection rate. So on the left, what you see is an example to show the virus completely. It has a high cytopathic effect. Cytopathic effect is where virus infect the cell and then replicate inside the cell and ruptures and then comes out of the cell and then infects the neighboring cell. So we saw more high cytopathic effect in one of these isolate that I'm highlighting here. The middle one is like low to medium, and then on the left one, pretty much we couldn't see any cytopathic effect at all, honestly. So we're starting to see that these viruses that we have isolated from the field has different virulence in infecting the cells. Genetically, they are different. They are also infecting the cells differently. And we have, in my lab, we have developed a human skin model where we actually get skin from mammoplasty surgery, and then we cut them in 1 centimeter squares, and then we grow them in a transfer plate. And this allows us to actually deliver the virus intradermally to the skin, and then we observe how this virus is replicating in the skin. So I'm just giving, summarizing this whole image and telling that the blue ones is our original laboratory strain that everybody is using, and the red, green, purple, and orange are the ones that we have isolated in the field. I'm showing only 4 just for an example, but we have done this for all 41 isolates, and they're all different. You can tell that the field isolates are less virulent in the skin, less infection, it produces less infection in the skin. However, the field isolated ones are highly virulent. So which means that definitely the field isolates are much more virulent than the laboratory strains, at least some of them. Some of them are almost the same. Some of them are highly virulent. So we got a lot of mixtures of this viral infection kinetics. And at the end of the day, we are a laboratory that uses mice in our studies. So we inoculated these clinical isolates, 41 clinical viruses isolated from the field. We actually monitored their clinical outcome. This is the table that we actually use to monitor, which is weight, appearance, neurological signs of disease, provoked behavior, respiration. And then we actually come with the cumulative score by adding all these things, and that is on the y-axis. And then the x-axis is the days post-infection. And you can tell that majority of these virus isolate that actually have put the legend at the bottom did not show any major cumulative clinical score. 8 of those isolate actually produced very high clinical score that we have to euthanize those mice, which means that amongst the 41, 8 viruses are highly virulent. The rest of them are moderate to low virulent as well. So we were able to identify field isolates with differential virulence capacities. So now my lab is doing the same thing for the Borrelia. So our ultimate aim is to actually identify a Borrelia strain and a Powassan virus from a single tick, and then use it to study our co-infection study. So that's the plan for us to move forward. Hopefully the next time when I give a talk somewhere, we'll have more progress on our co-infection based on the Borrelia and the virus isolated from a single co-infected tick from nature. With that, I would like to, thank my lab members and all tech submitters and our collaborators and the funders. So with that, I'll be happy to answer any question you may have. Thank you for the time.
Great. Thank you so much, Dr. Thangamani. One thing I know as the director of the SUNY Center for Vector-Borne Diseases, and also you're an Empire Innovation Professor at SUNY Upstate Medical University. Your research at New York's Upstate Medical University, can you describe any initiatives or partnerships that translate really into the clinical practice?
Yes, I think that it's a great question. So I'm part of an Upstate Global Health Institute where we do a lot of clinical trials and human clinical research. So we are actually engaged in multiple clinical research with my collaborators. I'm not an MD doctor, so we have tick-borne disease researchers in our team. They are also part of the Columbia Clinical Trials Network, where they are taking part in conducting a few clinical studies as well. And we have a vast collection of human samples that we are currently looking at the retrospective survey of human exposure to tick bites, human exposure to Lyme disease, and also Powassan virus. So we are actually engaged in a lot of tick-borne disease clinical research activities with our Upstate Global Health.
Wonderful. Thank you so much for that. Of course, I have another question.
Sure.
As you stated in your presentation, supportive treatment is the only option for Powassan virus infection. How does the timing of treatment impact patient outcomes?
Actually, unfortunately, delaying the treatment, because supportive therapy is the only treatment that you can do, but delaying the treatment will actually result in worsening the clinical outcome in the patient. For example, there is no point of care Powassan virus diagnostic test in a hospital setting. So they have to take the CSF and then send it to the state health lab, and then state health lab then sends to CDC. And for the CDC to come back and tell the data back to the clinician, it takes about 10 to 12 days or 10 to 15 days. So those are very precious days, right? You could have started a treatment on the person. So I think there are a lot of other reasons why a patient may not get an immediate treatment if they are suspected to have Powassan virus. It takes such a long time for diagnosing. And yes, if you can't detect it early and treat early, I think they will end up having lifelong or long-term neurological sequelae.
Thank you for that. And I do have one last question.
Go for
You
it.
underscored that co-infections such as Lyme disease increase Powassan virus replication. Is there any data yet about how the identification and treatment of co-infections may impact the outcomes of supportive treatment?
I don't think there is any treatment at this time, but that's something that I would like to work with our clinical trial center to see if there is a way we can actually assess that in a proper way. So now all we have now is anecdotal information. We do not have any clear research on that, but that's something that we would like to actually work on it.
Great. Thank you for that. And before I turn this back over to Mr. Jim Berger, my last sort of comment and question to you, as I've been asking all the other presenters, is there a message, a takeaway message that you would like to leave with our listeners here today?
Well, I think the biggest message I want to actually give is that it is very important that we have to investigate the epidemiologically relevant strains that are currently infecting humans, rather than 40-year-old laboratory strains that may not be even epidemiologically relevant. So that's one thing. The second thing is co-infection is a big thing in the sense that a single tick single tick bite can lead to multiple clinical outcomes. So it's very important to investigate co-infections, irrespective of Powassan or Lyme. I think there's multiple other diseases that we should be focusing on.
Great. Thank you for that. And I just want to say a huge word of thanks and gratitude to all of our presenters today, a wealth of information. And thank you for hanging in here with us to share this critical information. It is my pleasure now to turn it back over to Mr. Jim Berger. Jim, the floor is yours.
Hey, greetings, Kay. Thank you. And thank you for the audience and the speakers for today's presentation. I've got two things to address today. The first is really to go through a quick rundown of what we heard today. We heard Admiral Levine's remarks. She set the tone of the meeting to engage this community and the public in an informative manner to bring awareness to the mental health and neurological effects of the tick-borne disease and associated illnesses and conditions. Next, we heard Kay's great role as a moderator and questions to the follow-up to the speakers. It was well done and hit the key focuses on what the audiences wanted to hear. The next thing, we heard 4 clinical perspectives. We heard the neuropsychiatric aspects of tick-borne diseases and associated illnesses by Dr. Fallon. Next, we heard the neurologic Lyme disease in children. It was a preview of an ongoing clinical study by Dr. Nagrovic. Next, we heard it's not just about avoiding red meat, giving voice to the untold implications of alpha-gal syndrome by Scott Cummins. And then we heard a clinical toolkit that was for improving care of patients with prolonged symptoms and concerns about Lyme disease by Dr. Marks. And then we had 2 research perspectives. The first was one that addressed the brain changes and symptoms that correlates in Lyme disease by Dr. Sherry Marvel. And last, we heard the Powassan encephalitis, an emergent tick-borne disease of human health concern by Dr. Tanjamani. Next slide, please. Next, we've got our upcoming sessions. The first is going to be addressing the virtual community engagement sessions. There's going to be 2 of them. Session number 2 is going to be the diagnosis and diagnostics on January 28th. And the third session is going to be treatment on April 29th. And just a reminder, these were the sessions that we had from the San Francisco input from the community as to what they wanted to hear with our community engagement sessions that were going to be virtual. And our next public meeting is going to be in Portland, Maine on June 25th and 26th with more details to be provided. I also wanted to remind everybody that it'll take about approximately 2 weeks. We did record this session and it'll be provided on our webpage. You can go on there and that's where the session will be recorded. So with that, I close today's excellent community engagement session and look forward to meeting with you again on January 28th for that diagnostics community engagement session. Thank you.